This conference will now be recorded.
All right, so we're going to cover Chapter 32, environmental emergencies. After that, we're going to break into groups. We'll go out to the trailer, grab some stuff, bring in airway mannequin, airway equipment, and we'll do the patient assessment trauma station today. We're going to work on both of those. And we're going to just keep repetitive until we get it down, and just keep working through it. And then after that, around 2:30, we need to start CPR. It takes about 2.5 hours to get through it. So hopefully, this is charging here. We can make this work. So if not, I'll have to go back to a different projector. All right, so Chapter 32, covering EMS standard competencies, and then going more in depth on the environmental emergencies. So we're going to look at submersion incidents, temperature related, like hyper and hypothermic patients, so heat, cold related, the pathophysiology for near drowning, temperature related illnesses, bite, venom as well, dysrhythmias, which would be the high altitude or diving injuries. We're going to cover a little bit about that. I know that we're in a diving type area, especially with Winnipesaukee. We do a lot of diving out there as well. So just kind of an idea of what to look for those electrical injuries and then radiation exposure. All right, so medical emergencies can result from environmental factors. So we look at what populations are really at high risk. So obviously children, they're adventurous, right? They go out and do some crazy things. Looking at the elderly, especially with the cold emergencies, they really can't regulate their body temperatures that well due to their age. So with that, we need to kind of really look for that hypothermic female or male patients. Even if they fall in their home and they're on the floor for like 4 or 5 hours, they can still drain that heat right out of them. They can become very hypothermic quickly. Or if they fall in a bathtub and they're there for a couple hours, somebody finds them, just even being outdoors. So shorter periods of time, their bodies can't really regulate. They get cold fast. So it's like a pediatric or a child. They go into the water, and it's like we go in there like, hey, you know what? We're cold. We're going to get out. The kids just keep playing and playing until their lips turn blue, and they're like, you're a little cold. You need to come out. I'm not getting out. Yeah, it's time to go. It's time to warm up. So people with chronic illnesses, people that can't regulate stuff very well, and then also the young adults who overexert themselves and become hyperthermic. We've seen that a lot in the summertime where they just keep working. And next thing you know, they're so tired, they're too warm, and they start getting the heat exhaustion, heat cramps, to heat stroke. We're gonna start seeing that kind of stuff as well. We're gonna look more about the heat and cold related emergencies, water emergencies, pressure related injuries caused by lightning. It actually happens more often than people think, being struck by lightning and lightning emergencies like that. And then obviously the venomous insects, snakes, bites, things like that, and stings as well. So some affecting factors affecting exposure. So obviously patients who are ill or in poor physical condition will not tolerate extreme temperatures well. So people that are in really good shape can actually tolerate the temperatures pretty well. Also, thermal lining, insulating, keeping yourself warm, wintertime, or keeping yourself cool by not wearing as many layers of clothing outdoors. Age plays a big factor as well, with children and older adults that are more likely to experience temperature-related emergencies because of the poor thermal regulation and the ability to shiver for infants, where they cannot generate what they need till about 12 to 18 months of age. So kids or infants can get cold or too warm very fast, so they don't have the ability to shiver. So you can't tell if they're cold because they're not shivering, and then what's going to happen? The body temperature is going to drop down to the really low temperatures. So what is our normal body temp? What's normal? Yeah, 98.6. We start getting temperatures around 94. I mean, that would feel great outside, right? What does that do to your body, though? I'm just asking, 94. Yeah. So exactly. And then it starts going down from there. Um, when we do kind of like we have a cardiac arrest, what we do for what they call target temperature management is what they call therapeutic hypothermia, where you bring a patient's body temperature down. These are patients that are unresponsive, that come back from a cardiac arrest. We have ROSC, right? They have pulse, blood pressure. We bring their body temperatures down to 89. Okay, so outdoors it's 89 degrees today. These doors would all be open, fans would be on, we'd be sweating our butts off in here. To them, that's very hypothermic. Um, we start getting into the low 80s. These patients here are detrimental because if you have someone who's that cold, a simple bump in the road to a bump on a Stokes basket coming out of the woods off the ice or whatever can put someone into a cardiac arrest because their hearts are so fragile. Even looking at the ACLS side for the paramedic level stuff, we can't even push a bunch of meds because their body is just not pumping blood the way it should be because it's so cold, right? When we get into diving stuff, I'm not sorry I should say diving, but water stuff as well, we talk about mammalian diving reflex, and that's part of your body, is Mother Nature's way of shutting your body down, dropping your body temperature down. And it keeps your body alive. Everything just kind of slows. Where you may have a patient who comes out who's still alive with a heart rate of like 10, 20, because your body temperatures have dropped that low. So we're going to talk about that as well coming forward. So think about, the ability to put on extra clothing. They just want to go outside and play and do stuff so they get cold quickly. Older adults, obviously, the loss of subcutaneous tissue, which then would have a reduced insulation, poor circulation, and medications that also affect thermal regulation. They could be on those meds as well. All right. So nutrition and hydration. Obviously, the lack of food and water will also aggravate the cold or hot stress that you have. We gotta make sure we're hydrating well. If we do not drink plenty of water and too much soda, too many sugared drinks, that can dehydrate us pretty quickly, and the point of, or we can go into a severe dehydration. And severe dehydration will then change our electrolytes within our system, right? So if our electrolytes are changing, that starts throwing off different cardiac arrhythmias and things like that. So we need to make sure that we're hydrating appropriately so we can sweat appropriately to cool our body down and make sure we're drinking plenty of water. They do recommend a sugared water for patients that are very dehydrated. But literally, it's a couple of packs of sugar into water and they drink it for oral rehydration. In the cold, they don't recommend like the hot coffees and all that kind of stuff. They don't want the sugary drinks when you're really cold either. So like hot chocolate, great for the wintertime, but that amount of sugar is just not good for you when you're hypothermic. Right. So we'll talk more about that also. Also, another thing here as well is calories obviously provide fuel to burn, creating heat during the cold. One thing to also look for as well, this is more of street stuff. Patients that are shivering, that are really cold, even if they're a non-diabetic, check a blood sugar. Why is that? Why do you think that would be? Partially, but what is the body also doing though? Shivering, right? What does shivering do? Burning energy, right? So you can be shivering so much, you can burn so much energy to the point where it starts then taking over and burning fat cells instead, right? We start getting into that, then what happens? And our sugars start to tank. So check a blood sugar. You may have a non-diabetic patient with a blood sugar of 40. If they're hypothermic, shivering, and all that. So what happens when the body stops shivering? Right. So it causes the muscle rigidity and all that shivering, right? Creating heat. That's the point of us shivering, is to create the heat, right? And we sweat to cool our bodies down. If you lose the ability to sweat or lose the ability to shiver, is that good or bad? Bad, right? Okay. That means that our thermal regulators within our system are no longer functioning. We'll see that in severe hypothermia and severe hyperthermia. well, they'll lose that ability to no longer thermoregulate the system. All right, those are patients that are pretty much in shock. We got to look for those. So patients that have really cold body temp and they're not shivering anymore, they need to be rewarmed. They need IV therapy, warm fluids, heated blankets, the bear huggers, and we carry on all of these here. We carry 2 heat blankets. They're the heat pack ones that you open up and expose to air and they get really warm, like 130 degrees. We have 2 per ambulance here because of that. Because of the stuff that we deal with out here. They're like $30 a piece. They're one-time use. But we got them for severe hypothermic patients coming off the ice, the mountains, whatever. Also, alcohol will also change the body's ability to regulate temperature. What is it doing to the blood? Thinning it out, right? So environmental conditions, obviously looking at conditions that can, complicate or improve the environmental situation. Air temperature, obviously cooling, warming. But then the wind kicks in, then what happens? That wind chill effect, right? Because blowing over the patient. You got a patient that falls through the ice, right? Technician team goes out, brings the patient back in. They're still covered in water, cold. Say it's 30-mile-an-hour winds, it's 10 degrees outside. That patient needs to be exposed. You got to get all those wet clothes off them, right? So do we do it outside or in the back of the ambulance? Yes, back of the ambulance every time if you can. Don't ever expose them outdoors because they're already wet and cold. Once you get them trauma naked, that wind then goes over the top of the patient. It's going to freeze them, right? Severe hypothermia. So get them in the back of the ambulance, get all their clothes off. Please do not put the Stokes basket in the back of an ambulance. Not a lot of room for that, all right? Thought you were taking a nap. All right. So remember, when you get them back in the truck, take them out of the Stokes basket, then get them in the back of the ambulance. Get them off the board. Okay, get them onto the stretcher itself. Get them trauma naked, and then get some warm packs and pack the high heat loss areas, which would be what? Yep, groin, sides of the neck, right? So here, groin, neck, and then make them look like a nun. Okay, wrap their head. Hey, top of the head is also a big high heat loss area, right? So wrap the head, heat packs here. Don't strangle them. Okay, tuck them in. If you run out of heat packs, every ambulance should have an IV warmer on there, right? Should have IV warmers that work. Take them out of there because they're already warm. They're warm to 105 degrees and stuff them in the armpits, stuff them in the groins, and warm the patient up, right? Then you say to your driver in the front of the ambulance, hey, can you put these on the dashboard and turn the heat on high? Take your fluids and just toss them to the front. Heater vents on high for defrost, and then start warming your fluids. Other things you can do to help ALS providers also in warming stuff up is take heat packs and just tape them to the bag and then tape one at the bottom of the line. So as it comes through, the bag is warming with the heat packs, and as it goes into the patient, it goes through the warm part of the pack where it goes in. It heats the patient up that way as well. Little tricks, things that can help you with that as well. Obviously, humidity level. So obviously the humidity is not as bad up here as it is down in Florida. But again, humidity can definitely increase heat, make it worse for patients in the hyperthermic situation. Obviously, extreme temperatures and humidity are not needed to produce injury. So most hypothermia occurs at temperatures between 30 and 50 degrees. Okay. What about our water system up here? Is it below 70 year round? Yeah, year round, yeah, below 70. You may have if you have a nice, really Indian type summer, the warm summers like that, you might get something in the mid 70s for water, but it doesn't last long. Maybe a couple of weeks in July, and then it goes right down below 70 again. So we live in a cold water state all the time, whether it be winter or summer, it's still cold water. And those of you who have ever taken our water rescue program in the past, and you're in the water for 6 hours, you're cold. Even though it's beautiful 90 degrees outside, you are cold in the water. You start shivering yourself. Especially when it's raining and windy out. So again, most heat stroke occurs when temperatures are 80 degrees and the humidity is 80%. Start seeing that heat stroke stuff. So It usually starts off with heat cramps first, then goes to heat exhaustion, heat stroke. We're going to cover that more later on in the presentation. And examine the environmental temperatures of your patient as well. So older patients may not heat or cool their home sufficiently. Now, I've gone into patients' homes in the middle of winter and it's like 1,000 degrees in there, and they're like, really? You walk in like, let's get this patient out so we can stop sweating. But again, they may not heat it well, or maybe they're overheating it, and that's what's causing them to become dehydrated at home. All right, so you got to look at that kind of stuff as well. Hypo and hyperthermia does not just have to occur outdoors. It can happen inside too. All right, we've been to homes before. Most of us have been to homes where it's freaking cold in there, right? Now you take the cold, and if I walk in and I say that I'm cold walking into a house, right? I got a 90-year-old woman laying on the couch. You think she's going to be cold? Yeah, absolutely. She's already numb laying on the couch. So you got to kind of pay attention to those things too. Look at those different indicators and factors when you walk in. Is there a potential for this to be like this? So cold exposure, so if the body or any part of it is exposed to cold environments, temperature regulatory mechanisms may be overwhelmed. So cold exposures may cause injury to the feet, hands, ears, nose, or the whole body, which would be hypothermia. So there are 5 ways a body can lose heat. What are they? Yep, okay, convection, radiation, like fire school all over again, right? So conduction is a direct transfer of heat from a body part to a colder object by direct contact, right? So elderly patient falls down at home onto the floor. Floors are cold. Conduction, direct contact, losing body heat. Convection, transfer of heat to circulating air. So when the cool air moves across the body, right? So we just talked about that on ice rescues, mountain rescues, whatever. Outdoor falls. Even a slip and fall in the driveway in the middle of winter, same thing. Okay. Now you have conduction, pulling that heat out into the ground, and then you have convection, the cold air blowing over the top of them. They can become hypothermic quick. Those are questions you want to ask, though, right? How long has the patient been outdoors for? How long have they been on the ground? That's going to be important questions for us to know, because if they've been outside for a long period of time and they're hypothermic, right, we need to start treating that. So going into the next slide, how do we measure a patient's body temperature that is hypothermic? Keep going. Doesn't taste very well, though. Yes, you have to get a core temp. All right, so please don't check a core temp and then check an oral temp after. Then the patient's not going to like that too much, right? So if you're at the hospital, red is rectal, blue is oral. Please do not confuse the two when you're checking a patient temp at a hospital. Bad things happen. No, we clean those. It's okay. But rectal temp is what we have to do. We have to check the rectal thermometers. If you do not have one on your ambulance and you're in especially around here, get one. They're not that expensive. It doesn't have to be a super powerful monstrosity of a probe going in. A simple thermometer that's meant for rectal temp, just leave it there. All right, and see what their core temperature is, because you're going to have a big difference. You'll have patients, I mean, I've seen patients even that are septic, and they do that whole skin probe, it says, oh, it's 98.2. Man, but they feel really hot. I've gone in and then checked the rectal, 103. Okay, very big differences. Tympanics are better, the ones in the ears, but those skin ones, and as soon as you bring them outdoors, they skin. Remember, capillary bed's in the top. It's going to get cold fast. You're going to get false readings. You're not going to get anything accurate. So check them in the back of the ambulance, tympanic, oral. If they're really cold, you have to check a rectal. And even pediatrics, same thing, rectal temps. All right, so be careful when you bend their legs up to check it. Sometimes things come out like confetti. So you gotta watch out for those. Evaporation, so conversion of any liquid to a gas, so natural mechanism by which sweating cools the body, right? We're evaporating, we're sweating, we're getting rid of that moisture, okay? And then radiation, transfer of heat by radiant energy. So heat loss caused when a person stands in a cold room. People that are outdoors, okay? that start breathing heavily and things like that, loss of body heat. You can also lose condensation and fluid from breathing, right? Let's talk about respiration. So loss of the body heat during normal breathing. As you're breathing, all of us are breathing out, we're losing body heat, right? So we're expelling air. With that is also some condensation. There is some moisture to that. So warm air in the lungs is exhaled into the atmosphere and then is cooled as cooler air is inhaled. So we're taking a breath in, cold air comes in, it warms back up, we exhale, warm air comes back out. With that also comes moisture. If air temperature is above body temperature, an individual can gain heat. Okay. If they're hypothermic and they're breathing, we are losing body heat. We've got to warm them up. I'm not saying take a warm towel, put it over their mouth and nose, but what we need to do is provide humidified, heated oxygen, right? Now, do we have that ability to do that? We don't in any of these trucks. We don't have the ability to do heated. We can do humidified if we have the humidifiers for them. You can buy that. They do make heated oxygen systems you can get, but they're not cheap. Yeah, but how you can do heated, but it's going to cool down so fast. We're only putting 3 mLs of fluid in there, so it'll cool down once it hits the plastic. It won't stay warm for a long period of time. Nebulization does provide humidity, though. With it, I mean condensation and humidification. But again, that's just more weight that's there. But heated oxygen definitely does help in this process to keep patients warm, help with the internal rewarming of the body. So the rate and amount of heat loss or gain by the body can be modified in 3 different ways. We kind of talked about this already. So shivering and increased movement when cold, decreasing and limiting movement when hot. So bring them into a cool area, have them sit down, no moving, right? Let the body just start to cool. Seeking shelter from the wind or cold environments. Seeking shade in hot environments to cool the patient down. And then 3, wear the appropriate clothing for the environment, like layers of protection, right? If you're dressed for the occasion, dressed for the outdoors, whether it be warm or cold. Protective clothing traps perspiration and prevents evaporation. So loosen the clothing to cool them down. So if you have a patient that's really hypothermic, clothing off. Okay, even it's down to their underwear. Put the pants down, put the shirts off. Right. Remember, keep them decent. Okay, back of the ambulance or in a private area, and start cooling the body down. Other things you can utilize as well for hyperthermic patients. You could get the spray bottles of mist and just kind of mist them down. We do that with firefighting, with firefighter rehab, right? We have misting fans. There's one actually sitting on top of the cabinet up there. You know, it takes water, sucks water in, it puts out a mist to cool them down, helps with the cooling process. Below 95. Okay, that's our number. All right, so hypothermia number, 95 degrees or lower is hypothermic. So this is the body loses the ability to regulate its temperature and generate the body heat. So our body temperature is dropping and dropping. We got to start warming these patients up with an active process. So eventually the key organs, such as the heart, begin to slow down. The mental status starts to deteriorate. Remember the whole part about heart slowing down. We'll get into that during the water stuff too. But at this time, our body slows down, our heart slows down. Eventually we'll have the inability to pump. Eventually that will go into cardiac arrest if it gets too cold. We're talking like low 80s, right? If you look at, this can lead to death. So if you look at our New Hampshire protocols, okay, New Hampshire has a pretty aggressive hypothermic protocol that we have here. And in one of it, if you go to a stage 4 or a type 4 hypothermic patient, which has a temperature range in the low 80s, if you're within an hour of an ECMO center, they want you to transport to an ECMO center where they can warm the blood and put the blood back in, heat the patient back up. So for us, in New Hampshire, there's only 2 facilities that have ECMO. That's Portsmouth Hospital and Dartmouth. Okay, and so it's a hypothermic bypass protocol that you have. You have to contact your local hospital to bypass over, depending on stability of a patient. Right, Maine Med has it as well for Maine stuff. Maine Med has that as well. Right, but they got to find a way to rewarm the body. So air temperature does not have to be below freezing for it to occur. It does not have to happen that way. This can develop quickly or gradually depending on where the patient is, where they're located. Right. Again, we just talked about being in the water at 70 degrees, and being in the water for 6 hours, 5 hours, 4 hours, and our body temperature will drop. It'll feel great for probably about the first half an hour to an hour. Then you're gonna start saying, "Oh, it's gonna look cool." And we move around a little bit more. Now we're expelling energy and we're cooling our body. So again, your hypothermic patients, we need to check a blood sugar because once it no longer can burn energy, it'll start burning fat stores. So then in turn, we'll start dropping our sugars, become hypoglycemic. Remember, non-diabetics can become hypoglycemic, so check a blood sugar. It's no different than with runners. Same thing. Okay, you get runners that are cramping like you wouldn't believe after a long distance run or a marathon run. Check their blood sugar. I can almost guarantee you their sugars are low. It's causing the cramping. It's not just dehydration. It could be hypoglycemia. Check a blood sugar. That's why you give you a bunch of snacks after you run. They'll replenish some of that energy and that sugars you've already burnt off. Right? Because if you're running hard and you've burnt off all those sugars, you become hypothermic, right? Because you're running. That's why they do those ice baths at the end. You ever seen those before in the tents? Yeah, not for me. I'm not gonna jump in an ice bath. Temperature down, right? Because their body temperatures are running like 102, 103 degrees, so they're warm, very high body temps. We're also burning off energy and then burning off fat cells. Then we're also burning off our sugars. And we're going to start having hypoglycemic events. So check the blood sugar on those patients. People that are at risk for hypothermia, homelessness, or homeless people, and those whose homes lack heating systems, swimmers, geriatric, pediatric, and ill individuals. So patients that are, let's say, pneumonia or they have cancer, things like that when they're on chemo, they're sitting at home. Ill individuals can develop hypothermia pretty quickly. Hypothermia and sepsis is very bad. It's what they call cold sepsis. That's a body temperature of less than 96.4. Right. So we want to make sure we're checking body temps as well. Patients with injuries or illnesses such as burns, shock, head injuries, stroke, generalized infection, injuries to the spinal cord, diabetes, and hypoglycemia as well. And patients who have taken certain drugs or consumed alcohol. So you really need to make sure we're checking not only blood sugars, but also body temps. And if they're really cold, they might need to receive a rectal temp. So some signs and symptoms become more severe as the colder temperature falls, the core temperature falls. So progress through the 4 stages. We talked about these here. And this is kind of going along with what the state of New Hampshire has for a protocol. So we have 93 to 95 degrees, shivering and foot stamping, constricted blood vessels, rapid breathing, level of consciousness to be withdrawn. Signs and symptoms for 89 to 92, loss of coordination, muscle stiffness, slurring respiration, slow pulse, and then confused, lethargic, and sleepy. 80 to 88 degrees, coma, weak pulse, dysrhythmias, very slow respirations are unresponsive. At 80 to 88 degrees, those are the ones we need to move slowly. I understand they're critical, but a hard bump in the road, and we live in New Hampshire, we're going to have frost heaves. Right, that bump can trigger that heart to go into a lethal rhythm, a VTAC or a VFib arrest. Right, that's why it's so important to warm these patients up. Below 80 degrees, apparent death, cardiac arrest, and unresponsive. Okay, even though they are in cardiac arrest, you're not dead until you're warm and dead. You got to warm them back up. They have good chances of coming back. Okay, still, but we just can't push all that epinephrine because it's just going to sit there in the system and not move. And once the body temperature warms, all of a sudden all that epi you pushed every 5 minutes, it goes to the heart all at once. Then bad things will happen to that as well. You'll be over medicated in the system, which we don't want. So am I asking you to remember all these stages? know what they are. Know that when really cold is really cold, they need to go to certain facilities. If you have a hypothermic patient, also give the hospital a 30-minute ETA. Let them know what's going on if you have that kind of a transport. They need to get the bear huggers ready. And they don't have a bear hugger in every room. They have to go get them out of closets. All right, and that's a machine that puts heated air through it with a long blanket. And they put that between a patient, and they put a blanket over the top of that to control that heat to warm them. They work really well, but they got to get it all set up. They got to get all the parts together. So heads up ETAs so they can start planning for it. No. So assess for general temperature. Pull back your gloves and place the back of your hand on the patient's abdomen. Okay, check that cord. Just doing this is not going to work, right? This is all exposed to the environmental effects that are out there. Pull their shirt up, back of the hand, and feel their stomach. If that feels cold, the body temperature is down. They're probably cold, right? So then you want to check temperatures. Okay, another good one to do also is check an axillary temp. Just take a thermometer, put it in here, and come down on top of the arm. Check an axillary temperature as well. Works good with pediatrics if you can't get a rectal on them. Check them into the armpit, called an axillary temp. So mild hypothermia occurs when the core temperature is between 90 and 95 degrees. At this point, the patient usually will be alert and they'll be shivering. The pulse rate and respirations will be rapid because it's trying to warm the body back up again. So it's bringing in more of that heated, sort of the colder air, bringing the inhalation, warming stuff back up. So you're going to have a higher heart rate because now we're trying to bring blood and heat to the capillaries to warm the system up. All right. Skin may appear red, pale, or cyanotic. So the cyanosis being the blue tinted skin. More severe hypothermia occurs when the core temperature is less than 90 degrees. All right, so less than 90, our shivering is going to stop at that point. And your muscular activity starts to decrease. The patient will become lethargic and then stops fighting the cold at that point. The body just says, I'm done. Right? We don't want the body to ever be done fighting the cold. So we got to start rewarming these patients. So the patient becomes lethargic and stops fighting the cold. As the core temperature drops to 85, the level of consciousness starts to decrease, and the patients may try to undress. Right? Remember, they're altered; they want to take all their clothes off. Poor coordination and memory loss follows, along with reduced or complete loss of sensation or touch. Mood changes occur. The patient shows any impaired judgment. Patient becomes less communicable. The patient also experiences joint and muscle stiffness, has trouble speaking, and appears to be stiff and rigid at that point. So remember, 85 degrees or lower would feel great outside right now, but our bodies just can't deal with that. If the body temperature is 80 degrees or less, the pulse becomes slower and weaker. Cardiac dysrhythmias may occur. So our body's too cold, we're not circulating like we should anymore. Patient appears to be dead, or they could be in a coma. Does not mean that they're actually dead, right? This is where ultrasound comes into play too. If you had it on their ambulance, you could actually check cardiac function with that. Never assume a cold, pulseless patient is dead. If the core temperature is also less than 80 degrees, all cardiorespiratory activities may cease, and pupil reaction becomes slow as well. This is some of the things to think about when you're checking the responsiveness. All right, so local cold injuries. I got some pictures on the next slide for you to take a look at. So most injuries from the cold are confined to exposed body parts. Extremities, especially the feet and hands, the ears, nose, and face. So if you remember, feel like your cheeks here, feel your nose, right? Okay, capillary bed is here. Here, there's not a lot of tissue in between. That's why we start getting frostbite, cheeks, nose, ears, feet, hands, because we don't have the muscle mass or the fatty tissue like we do in the arms, the stomach, the chest, things like that. So these are also exposed to the elements a lot too, especially your face. So we'll start seeing the frost nip, tip of the nose here becomes very painful. And you guys have probably all experienced this before when you go outside in the cold for a while and you do this with your nose like that, and it kind of like stays there, right? because our capillary beds are just so cold, they're starting to freeze up. They're starting to become numb, right? And that'll cause us to kind of stay in one spot when we start moving. So warm these patients up, heat the ambulance. Even if it's uncomfortable for you, we got to warm them up. So turn your ambulance temperature to 90 degrees or warm blankets on them and get them to the hospital. So when the exposed body parts become very cold but not frozen in a condition called frostnip, or if they have an immersion foot, another one is called trench foot, or when the body parts become frozen, the injury is called frostbite. So you have frostnip, frostbite, the injury become frozen. Frostbite, you'll start noticing, I'll show you the pictures here. These are extremities and facial injuries. So as you can see, looking down here, you can see the cold injuries, the blistering, tip of the nose. All right, there's some local cold injuries. We see these here. Please do not start dipping them in water. Okay, we want to warm them that way. Wrap them up in a loose bandage and transport them. Let the hospital take care of the treatments over there. All right. So important factors to determine if the severity of a cold injury is how long they've been out in the cold. Remember I mentioned before, you want to ask about that duration, how long they were actually in the cold environment or on the floor, in the bathtub naked. You know, how long were they in the cold water for? Temperatures at which the body parts were exposed. So what was the temperature outside at that time? And then the wind velocity during exposure. So how windy actually was it? Now, I'm not saying to go out there and buy instruments for your ambulance to tell you wind speed. Just look it up online. All right, and say what is the wind speed today on average. You should also investigate the number of underlying factors: exposures to the wet conditions, and adequate insulation from the cold or wind, restricted circulation from tight clothing or shoes, or circulatory diseases, fatigue, and poor nutrition as well. Other factors would be alcohol or drug use, right? Hypothermia, diabetes, cardiovascular disease, and age. So patients with hypothermia should also be assessed for frostbite or other local injuries. So again, you got to take off their clothes, you take off their socks, their shirts, look for other injuries potential that are there, right? The last thing you want is to have them have a cold exposure to their feet. They saw their socks on, you didn't check it, you didn't wrap it, you didn't treat it, and they get to the hospital, they pull their socks off and go, why didn't you guys tell me about this? Expose your patients and look at it. All right, so frostnip or an immersion foot. So frostnip is after a prolonged exposure to the cold, skin may freeze while deeper tissue is unaffected. So like you saw in that guy's first picture there, the nose, a frostnip over here. Usually affects ears, nose, and fingers because, again, very limited tissue, mostly bone and skin, a little bit of muscle in there somewhere. Usually affects, usually not painful, so the patient often is unaware that a cold injury has occurred. You ever noticed that before when you're outside and you have that numbness, but you don't notice there's an injury? You look at the mirror and you see this big red spot right here, right? Or around here. And it gets worse the higher you go to your zygomatic one of your cheekbones here. Okay? You'll start noticing the redness on the bone itself. Usually here, the cheek here, you won't notice it as much as you would right here. So where that bone and skin touch, you'll notice the deeper injuries will be there located. Immersion foot or trench foot occurs after prolonged exposure in cold water. Common hikers or hunters will stand for a long period of time in rivers or lakes. They're standing there, even if they have protective rubber boots, it still gets cold, right? So trench foot or immersion foot can start becoming possible for these patients. So signs and symptoms would be skin is pale or blanched and cold to the touch. Normal color does not return after palpation of the skin. So just by touching the skin like this here, if there's any normal color coming back, it's more like your cap refill. The skin of the foot may be wrinkled, but can also remain soft for these. And the patient reports loss of feeling and sensation in the injured area. So they'll be able to do this here, and they're like, oh, I can't feel this at all. Because now their nerves and their sensory have now frozen. So you got to warm these patients back up again. All right, this is frostbite, which is a more serious local cold injury because the tissues are actually frozen now. If you're past that frostnip stage, now we're in a frostbite. Freezing permanently damages cells. Okay, so this can cause a lot of damage to the system. The exact mechanism by which damage occurs is unknown. So gangrene, which is a permanent damage or the cell death, requires surgical intervention and removal of dead tissue. The exposed part will become inflamed, tender to the touch, and unable to tolerate exposure to the cold, as you can see in the photo. If you have patients like this, just take 4x4s, especially in the hands, feet, toes, place them in between like this, like you would for a burn patient, and just wrap gently, right? Prevent them from touching each other. And just wrap with gentle gauze, and then transport them. Signs and symptoms: most frostbitten parts are hard and they look waxy. The injured part feels firm to frozen as you gently touch it. Blisters and swelling may also be present. Do not pop the blisters, okay? As tempting as it is, do not do that. Leave the blisters there and wrap, like I said, wrap around them. A light-skinned individual with deep injury, the skin may appear red and with purple and white, or mottled or cyanotic. Right? So patients have lack of oxygen circulation to whatever that extremity may be. So you're going to see that bluishness or that pale. Again, wrap it up, start doing some rewarming. The depth of the skin damage will vary depending on where it's located. So the superficial frostbite is only the skin is frozen. With a deeper frostbite, deeper tissue obviously being frozen, and you may be able to tell superficial, and not be able to tell superficial from deep frostbite in the field. Yeah, it's all done through imaging and everything else. See how bad it is. Either way, bring them to the hospital. We need to get rewarmed, and hopefully they don't have to lose a finger or a foot based on the severe frostbite. That can turn into, like I said, the gangrene infection gets into your system, and that can lead to a lot worse of a time, including death, especially when you have extreme vasodilation and sepsis. All right, so scene safety. Note the environmental conditions and ensure the scene is safe for you and other responders. Identify the safety hazards such as icy roads, mud, wet grass, and use appropriate standard precautions. Please be careful walking to patients so you don't fall and hurt yourself. Last thing you want is become injured, then you become a patient also. Then you're just embarrassed because every ambulance has to show up and help you. Consider the number of patients. How many patients do we have? Wintertime, ice rescue, same thing. If one goes through, if some bystander goes out to help, what's most likely going to happen? Patient number 2, right? Water rescue, same thing. People go into the water to help other people that have no clue how to swim or do the appropriate techniques or the right equipment. Next thing you know, they become a victim, right? Cold exposures. A lot of times people walk out in groups, especially out here for hiking. I mean, more power to the people that hike in the winter. That's not for me. I'm not going to go hiking in the middle of winter. I like to stay where it's warm. But again, they go out and they hike, they get lost. Then what happens? They got to prepare for the overnight. A lot of people don't prepare for that. They don't go out there with a quick pop-up type tent with them or whatever it may be, just for shelters. And next thing you know, we're getting called for a missing hiker, missing group. We get out there and they're all hypothermic. It's a lot of people to be dealing with, especially when out with a bigger group. So again, just number of patients, how many they were, and get additional help as quickly as possible. And look for indicators of MOI and NOI. Form a general impression and perform a rapid scan. Remember, your rapid scan is your 60 to 90-second assessment. If a life threat exists, treat it. Evaluate temperature. If they're that cold, you have to check a rectal. Okay, sir, I'm going to be putting this down below. I got to check your rectal temp. Right. Evaluate the mental status using an AVPU scale. Then alter level of mental status can be affected by the intensity of the cold injury. So the colder you are, the more altered you're going to become, right? And you got to be careful of your safety with altered patients because that can change, right? Altered patients can become combative. The nicest person could turn into a complete, complete jerk in the back of the ambulance. We've seen that with diabetics too. We've seen that before. The nicest people, they become diabetic emergency hypoglycemic, and they're combative. They're swearing at you. Yep. And when they finally come to again, they're like, "What happened? Oh, you just called me every name in the book. Oh, thank you." oh, I'm so sorry, I didn't mean to do that, you know. So again, altered people can change. So just be ready for that. If the patient is in cardiac arrest, begin compressions. All right, airway breathing, assess the airway. Warm humidified oxygen helps warm the patient from the inside out. So if you have the ability to do that, do it. Palpate for the carotid pulse and wait up to 60 seconds to decide the patient is pulseless. Right? What do we teach you in CPR? What do we teach you guys? No more than 10 seconds. Look, listen, feel, nothing there, start compressions, right? With hypothermic patients, we have to wait 60 seconds and actually try to feel for a pulse. So take that extra time for that hypothermic patient. The AHA recommends that CPR be started on a patient who has no detectable pulse or breather. Perfusion will be compromised based on the degree of the cold the patient is experiencing. The patient's skin will also not be helpful to determining shock. Okay. So assume that a shock is present and treat accordingly. Bleeding may be difficult to find because of the slow moving circulation and thick clotting because of the body so cold. Right. So you have to literally expose your patient to look for any kind of major bleeds. Because remember, the body is cooling down, therefore it's not going to be, bleeding as much as it probably should be, which in your be to your benefit, right? We're slowing the bleeding down, but also in turn, though, it's making the patient hypothermic. What to remember, though, is just because you put a 4x4, 5x9 trauma dressing over there and the bleeding is controlled, what happens when they start warming up? What's going to happen to that bleeding? It's going to go faster, right? So it's start bleeding more. So you got to just reassess every intervention that you do. Complications can include cardiac dysrhythmias and blood clotting abnormalities. So all patients with hypothermia require immediate transport. Yep, we've already covered that. They need to go somewhere. So contact your local hospital. Say, where would you like me to go with this patient? All right, patient's got a core temp of 82. All right. Well, they're not going to ask you to be stable. Obviously, they're not stable, but can they make it to an ECMO center, or could they need to go to the local facility first? And talk to the doc. Consult the physician with patients like this. Especially the surgical interventions may have to be done with like severe frostbite. They may have to go to a place that can do surgery. So again, contact medical control and ask them. Say, hey, can you guys take this patient? Yes or no? Okay. So rough handling of a hypothermic patient may also cause cold, weak, hard to defibrillate. So you want to make sure you pay attention for that as well. Investigate the chief complaint. Obtain a medical history. Now, obviously, they're unresponsive. Look at their medications. Okay, you can tell a lot about history with the medications they take. Right. Obviously, now you guys are still just getting into this. You're going to learn them. So learn the meds. A way to really learn medications is interfacility transport. So they give you a whole H&P and all the meds are there, and you can learn about what they do and what they are. But again, learn the medications. If you have that unresponsive patient, you know nothing about them. That med list will help you tremendously. So get your sample history, allergies, medications, medical history. Last oral intake events leading up to the illness or injury. Find out how long a patient has been exposed to the cold environment, and exposures may be short or prolonged. So again, how long have they been down? How long have they been exposed for or to, and what they've been exposed for the environment, whether it be heat or cold. Physical examinations, we're going to focus on the severity of the hypothermia. Again, we have to check temps. So rectal temps are going to be needed. It may be multiple, right? Now, granted, if we're in the back of the ambulance, we have a maximum transport, average time is about 25 minutes, right? So you may check it once or twice during transport to see if there's any differences or changes. We're going to assess the degree and extent of damage. How much damage has happened with this cold emergency? Patients that are hypo and hyperthermic are not stable patients if they're severe. So put your vital signs every 5 and just monitor them. Look at your trends, right, as we go through it. So vital signs may be altered by the effects of hypothermia and be an indicator of its severity as well. Respirations may be slow and shallow, resulting in low oxygen levels in the body. Now, Pulse oximetry. It's a tool. It's a great tool to have. But patients that have cold extremities, are we going to get accurate readings? No, we're not. Now, there are ways to change sensitivity on our cardiac monitors that we have to help read through the colder skin, but it may not work. Okay, so they do make other options for pulse oximetry. They have the ear probe ones that hook on the ears that could help you as well. But again, it's a tool in your toolbox, but the best tool that you have is your brain, your mind, your assessment techniques. Look at your patient, right? Do they appear that they need oxygen? Are they cyanotic? You can tell cyanosis, right? Looking at your patient. Give them some oxygen. Give them nasal cannula, 4 liters. To warm the patient back up. Humidified, heated oxygen if you have that system on your ambulance. Low blood pressure and a shallow pulse indicate moderate to severe hypothermia. Right? We got to keep checking blood pressures. There may be a time where your auto BP is no longer going to work on this patient, especially if they're that cold and the blood pressures are that low. So you have to go back to the way we taught you. We're going to teach you throughout class. Manual blood pressure. Evaluate changes in mental status. Keep asking them questions to see if anything changes. And we're going to use the AVPU scale for the assessment. Determine a core body temp using a hypothermic thermometer, and pulse oximetry will often be inaccurate, which we just talked about. We're going to repeat the primary assessment, so go right back through. Check ABCs, go right down through your rapid assessment again. Look at anything that was immediately done for any life threat, go back and check it. Remember, we're warming the patient up, so things can change as they warm. Snowmobile accidents, middle of winter, let's say they hit a dock. Ouch, right? Potential for a lot of injuries. They've been outside for 3 hours on the ice. When they start warming, you're going to start seeing changes, okay? Especially in broken extremities. That cold is keeping that swelling down. Once you get in the back of a warm ambulance, they blow up like balloons, right? So you got to look for those injuries, okay? What you may not have noticed for, let's say, on the radial fracture, you may not have noticed it initially. Once you get the warm air into them and they start warming up, they start swelling more. So you got to make sure you do that reassessment and look at everything, okay? When I keep mentioning the word trauma naked, they need to be trauma naked. You've got to get them down, right? You got to expose them and look at them and assess them and touch them, palpate them, go right down through. Things change as the body warms, so look for those changes and then document it. Rewarming can also lead to cardiac dysrhythmias. So severe hypothermic patients should have ALS on board, at least an advanced EMT, right? We got to get a cardiac monitor on the patient. Now, yes, you guys can do 12 leads as EMTs. Get one, right? Do all of your life-threatening treatments first, get your first set of vitals, then get them onto a 12 lead and get a printout, right? Because there's other things that paramedics are going to look for in an EKG that could change depending on how warm the body gets before the medic gets there. So get a 12 lead, get a printout, and save that printout. So when the medic jumps on board and say, I got this within 15 minutes of patient contact, here you go. Other interventions, review all treatments that have been performed. Again, go back and look at everything that you've done. Make sure it's all doing well. If you had a person that had a laceration, again, if you bandaged it and they're cold, they're not going to bleed as much as they are when they start warming up. That could change. You need to put more pressure on it, more bandaging on it. Okay, so just be ready for it. Remove any wet or frozen clothing, cut it off, get it off of them, and then reassess oxygen delivery. Do we still need it, or do we need to start putting more oxygen on the patient? Do we need to increase their oxygen levels? All right, so when they start warming up, we get an accurate pulse oximeter reading. Do we need to increase our oxygen flow or not? So just check it out. Patient's physical status, communicate all the information you have gathered to the receiving facility. So what you found initially, how the patient presented to you, interventions that have been done, reassessment of interventions, and then vital signs, right? If the patient's unconscious, the nursing staff and the physicians are looking for more information from you. Like, do they know if you have any allergies, medications? What is their medical history like? People say, I don't know about allergies because they're unresponsive, but I do know that this is their med list. This is what they appear to have for medical history. Okay. So again, learn that stuff and get that information to the physicians. Conditions at scene, what you found, what you had. It's no different than a trauma. Take pictures with your phone, right? So if you have a motor vehicle accident, same thing. Take pictures of the crash. You can explain the crash to a physician and they'll be like, okay, pictures speak more than words. Show them a picture of the crash. Show them a picture of inside the vehicle, right? You got a hypothermic patient, show them the area they were in. Take a picture of it really quick. And again, don't delay patient care. Have your partner, have a firefighter on scene take it for you. Have them text it to you. That's not HIPAA at all. There's no patient demographics on it. We're showing this for patient care. On top of that, motor vehicle crashes, I know it's a little off topic from this, but we're talking about picture taking. Your pictures on your phone, you can upload to your run report. What a pretty neat run report that would be, huh? If you had pictures of a motor vehicle crash and the inside of the vehicle, the outside of the vehicle, and you uploaded that to your run report. So that's why you have fire do it, right? Because we know all the firefighters where we work, right? You know, you're not going to go to an area and not know people. Eventually, you'll pick up who they are, right? Say, hey, can you guys have pictures and just text that to me when you can, right? Like helmets, same thing. Bring the helmets with you. Okay, snowmobile accident, even if they're out in the middle of the snow and they're hypothermic, grab their helmet because that's going to show if there's damage to the helmet of where the impact injury might have been. Okay, so bring stuff with you. Motocross stuff, same thing with motorcycle racing. Those suits, those guys sweat. I've had many, many motorcycle accidents I've been working at the track. And they don't like you when you cut off their leather suits either, by the way. Right? Not a fun time at all. Absolutely, they are. I've had guys that have had 3 or 4 broken ribs on one side, flail, crepitus. Like, you're not cutting my suit off. They're just doing this. When I take the suit off, I'm like, oh, God. I'm not going to medicate you first. I'm either cutting this off or it has to come off. You're taking it off of me. All right. Forget C-spine. I mean, you just hit the wall doing 100 miles an hour, but, you know, you're up walking around. All right, so move the patient from the cold environment, remove wet clothing, and dry blankets under the patient. Remember, conduction, right? Got to warm underneath too. Those backboards and scoop stretchers are cold. Pad underneath them, warm them up, okay? Same thing with stretchers. You got a sheet down, blanket down, and wrap them like a burrito, all right? Heat packs inside, control that. On a side note, wrapping patients are a good thing. It contains the smell, right? So you got a code brown. If you wrap them and cover them up, it keeps the smell more intact. All right, if available, give the patient warm humidified oxygen, handle the patient gently, do not massage the extremities, okay? Don't give them the full body massage, and do not allow the patients to eat or use any stimulants at all. They're cold. When the body warms up, blood starts to flow. Okay? So keep that at ease. Do not allow patients to eat. Some of the things are example would be coffee, tea, soda, tobacco. All right, stay away from all that stuff right now. To the hospital. Mild hypothermia, obviously the patient is alert, shivering, and responds appropriately. So we're going to place the patient in a warm environment and remove the wet clothing. Apply heat packs or hot water bottles to the groin, axillary, and cervical regions, so sides of the neck, head, armpits, groin, and give warm fluids by mouth. Okay, not coffee, not hot chocolate. All right, you can do warm sugared water. Take all packets of sugar, put it in warm water, have them drink that. Okay, just stay away from all the extra caffeinated stuff. Do not try to actively rewarm the patient. Rewarming may cause a fatal cardiac dysrhythmia, okay, for moderate to severe hypothermia. Local protocols may dictate the appropriate type of rewarming strategies based on the patient's body temperatures. Look at your Maine protocols, look at New Hampshire protocols, and see what they need to follow. Remove the patient immediately from the cold environment. Okay? Don't leave them outside and start doing an assessment. Get them warm. Get them in the back of the ambulance, crank the heat. Heat, if you know you're going to a hypothermic type call, the heat should already be turned on in the truck before you start going. And then when you get there, it's warm. Okay. The goal is to prevent further heat loss. To remove the patient immediately from the cold environment, place the patient in the ambulance, wet clothing off, cover the patient with blanket, and transport. You're going to handle the patient gently to decrease the risk of BFib. If you cannot get the patient out of the cold immediately, move the patient out of the wind and away from contact with any other object that will conduct heat away from the body. So you may see some of this stuff potentially coming down from the mountains, right? So even ski accidents, same thing. They're going to be out in the cold. Ski patrol has to get there and bring them down, right? They might meet you at the ambulance. They could meet you at the clinic, depending on which one they're going to go to, especially the first aid station. Cover the head and neck with a towel, or make them look like a nun. Cover them right up. Always remember that even if the unresponsive patient may still be able to hear you, right? So don't start making fun of them at all. I just uploaded that this morning. It's going to be loud in here in about a half an hour or so. Moving trucks around. So again, remove the patient from further cold exposure. Some of the emergency treatment of local injuries in the field should include the following steps. Get them out of the cold, handle the injured part gently and protect it from any further injury, and remove any wet clothing or restricted clothing from the patient, especially over the injured part, right? So if you can't take it off, cut around it, cut it off so that your injured part is exposed, and then we're going to wrap it up, right? Not tight, a light dressing over it. But all that's going to do is prevent more infection from getting in from the outside, right? We're just going to wrap it up nice and light. It also allows for swelling, exactly, yeah, when they start warming up. The last thing you want is make a nice tight wrap and they start swelling, then it cuts off circulation. Like, why are their hands turning purple? Yeah, this swelled up a little bit. If there's no chance of re-injury, or if transport to the ED will be significantly delayed, consider active rewarming if local protocols allow. So consult medical control if available. With frostnip, contact with a warm object may be all that is needed. Your hands, your breath, your patient's own body heat will usually help. The affected part will often tingle and become red in light-skinned individuals. With immersion foot, remove the wet shoe, boots, and socks. Start rewarming the foot gradually, protecting it from further cold exposure. Do not stick them in warm buckets to start warming them up, heat packs, things like that. Never rub or massage the injured area. Rubbing can cause further damage to the cells and the nerves. Do not re-expose the injury to the cold. With late or deep cold injury, frostbite, remove any jewelry from the injured part. All right, swelling, jewelry can also cause restriction, so we have to cut it off. Do not allow the patient to stand or walk with a frostbitten foot. Okay, don't know they need to sit down, stay or chair them out. Splinting a frostbitten extremity may also help prevent secondary injury. So if you need to splint it, and evaluate for signs and symptoms of systemic hypothermia. And then we're going to transport the patient promptly to the hospital. Rewarming in the field, if prompt pre-hospital care is unavailable, again, and medical control can instruct you to begin rewarming in the field, use a warm water bath, okay, if we have the ability to do that. So again, medical control first before we do it. Immerse the frostbitten part in water with a temperature between 102 and 104 degrees. We're going to check the water temp with a thermometer before immersing the limb. Recheck the temperature frequently during the rewarming process. If the water temperature should never exceed 105 degrees. So we have to continuously monitor this water temp. Stir the water continuously and keep the frostbitten part in the water until it feels warm and sensation has returned back to that extremity. Dress the extremity with a dry, sterile dressing, including between the fingers and toes, like I mentioned before, between them like this, like you would for a burn patient, same thing. Pad in between so it stays spread apart so they don't touch together. then gentle wrap over the top. If blisters have formed, please do not break them. Cover the frostbite in part with a soft padded sterile cotton dressing. All right, one more slide here, and then we're going to take a 5-minute break. If you are at risk for hypothermia, if you work in a cold environment, protect yourself. If the cold weather search and rescue is possible in your area, you need survival training or precautionary tips. Remember to wear appropriate clothing. Okay. All right. Let's take 5 minutes.
This conference will now be recorded.
All right. So let's talk about heat exposures now. We touched on the cold. Let's look at the heat stuff. So in a hot environment, the body tries to rid itself of excess heat. By doing so, it starts to sweat, and evaporation of the sweat itself. So sweating starts to happen. Dilation of skin, skin blood vessels are to dilate. Removal of clothing and relocation to a cooler environment. So we got to get these patients out of that heat and into a cooler environment. Whether that be a perfect example, firefighter rehab. Turnout gear gets warm, especially in hot days. Fighting fire, 1,000 degrees inside of a building. Air packs, everything else running, a lot of heat, weight. Right. The best thing to do is get them out of their bunker coat, air packs, take off their bunker pants down to the boots, let them cool down. Okay. 20 minutes in rehab because we follow NFPA. Right. And then they go back to work as long as vital signs maintain. Okay. Whatever they have a heat exposure. If they have a heat exposure, we've got to cool them down. Whether that be through misting fans for multiple people that are overheated into a tent, or if we actually have like a single person with a heat exhaustion and things like that. The big difference between heat stroke and heat exhaustion is one thing that differentiates between the two. That's major differentiation, and that is mental status change. When you have an altered mental status, you are now in heat stroke. All right, that is the big change you're going to have. There are obviously other minor things there, but the big one is if they are overheated and they are altered, they have heat stroke. All right. Temperature also plays a factor in this, but that altered mental status is that big key thing. All right. So once they're altered, we start. That's heat stroke right there. Right off the bat, it's heat stroke if they have altered mental status. Hypothermia is a core temperature of 101 or higher. Okay. 99 is fine. Some people live at 99.2 as if it's a normal body. They just run warm. It's okay. 101 or higher, we need to start looking at heat stroke. Or not, sorry, heat exposure, I should say. All right. So, do you run warm at all? Maybe else run higher temperature than 98.6. Yours is low, cold-hearted. So obviously, high air temperature reduces radiation. High humidity reduces evaporation. Lack of acclimation to the heat, or vigorous exercise. So if you lived your whole life in New England, you say, yeah, I'm going to pack my stuff and move down to Louisiana. Right? See you in 6 months when you realize it's too warm. Right? If I go down to South Carolina, I go down there quite often. Florida, I do a lot of trips down there because I like the warm weather. But it takes my body 2 to 3 days to start acclimating to the weather, to the heat. After that, I'm fine. You can make it 85, 90 degrees outside with humidity, and I'm perfectly fine. But it takes me 3 days to change my body to acclimate to the weather. Right off the bat, I mean, I'm wearing shorts and a t-shirt, and it's 80 degrees outside. I'm sweating. I'm like, God, this sucks. This is horrible. My body needs time to acclimate to what's there. So that can happen a lot coming up north. People that live in the south, they come up north, and they start getting cold quick. It can be 50 degrees in the Carolinas, and I'm wearing shorts and a t-shirt. Everybody else is bundled up in winter clothing. They're all looking at me funny because this is what I'm used to. This is I'm used to the cold. They're not. So I was in the swimming pool in February. In the swimming pools, no one else was in there. Like, oh, it's so cold. They're wearing pants and sweatshirts outside. I'm wearing shorts and I'm swimming in a pool. you know, and they're looking at me like, oh, you're crazy. From Maine. They go, that makes a lot more sense. Yeah, it's just how it circulates and how it adapts to the current temperatures that are there. Exactly. And the oxygen changes. Yep. 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 You got to acclimate. And once you acclimate to the weather, you're fine. So we start seeing those changes. Look for the heat exposures. Persons at greater risk of heat illnesses are children, especially newborns and infants. Remember, they don't have that ability to regulate yet. Geriatrics, because they've lost that ability to regulate with muscle fatigue and weakness and changes. Patients with heart diseases, COPD, diabetes, dehydration, obesity. Patients with limited mobility, alcohol and certain drugs also make a person more susceptible to heat illnesses as well. Depending on what kind of medications they're on, it can change a lot of things within the system. Heat cramps are a painful muscle spasm that occurs after vigorous exercise. So remember I mentioned about marathon runners, things like that can start cramping up. That's why they do those cold baths to drop that body temperature and help regulate the system. Do not occur only when there is hot outdoors. Exact causes is not well understood. Dehydration may play a role in the development of muscle cramps. So when you start dehydrating, what are you losing? What was that? Electrolytes. Yep. So we're losing potassium, sodium, magnesium, all these electrolytes that help keep our body at homeostasis and hydrated. Okay. When we start sweating all those out, we have nothing to replace it, become dehydrated. And people that have changes in sodium, potassium levels like that, right, calcium, all those play a factor in your cardiac conduction cycle as well. So you can have arrhythmias and things like that, also cramping, right? Which is why, what was that? The big truck? Which is why we have to make sure that we are staying hydrated. So a lot of times the patients that are here require ALS intervention, depending on how bad the heat cramps are, because they can replace it with something called lactated ringers, which is a bunch of electrolytes mixed into a saline, and we can administer that, right, to help replenish that. Usually occur in the leg or abdominal muscle. It starts getting the cramping here and then in the lower legs, right? So we got to cool them down, rehydrate them, and a lot of times that cramping will go away. You may also notice some nausea as well with this, especially in the heat exhaustion. So most common illness caused by heat is heat exhaustion, also called heat posturation or heat collapse. Some of the causes would be, obviously, we talked about hypovolemia as a result of the loss of water electrolytes and heavy sweating as well. People work or exercise vigorously. As we know, people go out there and do workouts, things like that. Even the people that are even the most athletic can still develop heat exhaustion depending on what's really going on. Hey, Ron. All right. So again, people who wear heavy, warm clothing. So wrestlers, to make weight, what do? I'm not talking about wrestling that you see on TV, the scripted stuff. They train and they sweat. And what do they have to do to sweat? And they do trash bag running and working out. You ever seen that before? Where they cut a hole through the top of a trash bag over them, and it helps them sweat more so they can lose that water weight, which therefore in turn is making them dehydrated, causing that electrolyte imbalance, which then turns into potential cardiac arrhythmias. That's how they cut weight enough. That's it. Right? These guys train in these bags. They train in these sweatsuits. Then they weigh in, and then they can eat whatever they want. Then they hit protein hard and carbs. They'll carb and protein before a match. So they'll diet, starve themselves, trash bag, workout. Okay, weigh in, they meet the weight. Then they can eat after that. right? Boxers do it, MMA fighters do it. All these guys that do UFC, it's the same thing. They got to meet a certain weight class. In order to do so, they have to work out and get to that point, right? But that's when they start getting sick, because now they've starved themselves for so long to meet that weight. Because they could be 2 pounds over, and then they don't meet their weight class. They can't wrestle. They can't fight. So they got to drop those 2 pounds. Those 2 pounds may have to happen in the course of 3 days. So that's what they do, is they work out and they lose that water weight, and then after they weigh in, you could gain 2 pounds and they wouldn't care. It's just that weigh in. So you got to watch for those things, the heat exhaustion, and that's what's going to happen. People that do the running, the exercising, or even just outside doing yard work. I've been to a lot of heat exposures before where we've even had the elderly run outside doing gardening, but it's like 100 degrees outside. Next thing you know, they have heat exhaustion, so their body can't regulate very well. And also, they're outside. Oh, it's so cold out, and they're wearing sweaters outside doing yard work. It's like, what are you doing? And then they overheat. Then we get called in. Yeah, that shouldn't happen. Sam was just here and grabbed a bunch of straps. Okay. All right. Other symptoms would be dizziness, weakness, and syncope with heat exhaustion. Our body's going to get so warm, we're going to pass out. When we pass out, it's our body's way of trying to reset it, okay? But syncope can be caused by other things as well, right? Like cardiac events. So did the dehydration and the reduction of electrolytes cause the patient to have a syncopal episode? Maybe. Did the dehydration cause hypotension because now you're hypovolemic because you have no more fluid in your system? The patient was sitting down and stood up too fast. They vehicled themselves down, and so they pass out. Could that happen? Absolutely. So just because you think it's heat does not mean that it's necessarily just heat exposure. It could be something underlying like cardiac because of the heat exposure they had, right? So don't just look and get tunnel vision on, oh my God, we got to cool these people down. They also need to be put on a cardiac monitor. 12 leads have to be done on these patients because it could be a cardiac electrolyte imbalance causing an arrhythmia. And if you can catch that before you cool them down, you hand that strip off to the paramedic and they go, oh, okay, this is great. They had flattened T waves on their EK on their 12 lead, which would be a patient that has low potassium because maybe they sweat it and piss it all out, right? So there's some things to look at. As you get that early recognition of a 12 lead, get that printout. Even at the EMT level, you're not reading it. All you're going to do is write down the computer interpretation of what it is and hand that to the medic coming on board. And then go, okay, now I know how I'm going to treat this patient. I'm going to give them more ringers, hopefully build that potassium back up, that sodium, and everything else that you're going to see in the electrolyte imbalance. So that's what we're going to look for. So getting that heat exhaustion, people think, oh, just cool them down, they're perfectly fine. Not necessarily. If they sweat it out and they're dehydrated, we're going to see vital sign changes. So they're not going to meet homeostasis. So you got to get back to that fine balance. That's how we're going to do it. We got to do treatments. Even with heat exhaustion, as long as they can still maintain their own airway, you can still give them oral rehydration. There's nothing wrong with giving them sugar water, but not caffeine. Caffeinated drinks are bad, whether it be hypo or hypothermic. Caffeinated drinks are bad. All right, cool them down. Water drinks. You can do Gatorade, you can do Powerade, but you have to mix it 50-50. Right, so it tastes like crap, but it has electrolyte change, right? Because electrolytes and Gatorade and everything else that they need to replenish, but they don't want all that sugar. You got to be careful about the sugar with those patients, right? Onset of even at rest in older patients, infant age groups, poorly ventilated environments or extended time in hot, humid environments as well. So people that work in warehouses, and it's like 100 degrees outside, that have crappy ventilation indoors, they can get heat exhaustion pretty quickly. Dry tongue and thirst. So when you're doing your assessment, have them stick their tongue out at you. Right, we're looking for is that pitting whiteness in the tongue. So they do this. And it's all white. They're dehydrated. If you have someone, like let's say in their mid 20s, 30s, and you do this to their skin, it's called skin turgor. We're going to check. Okay, if I let it go and it stays up like this, right, very dehydrated on those patients. With elderly, though, a lot of times they'll stay anyways, right, just over time with skin. But it shouldn't stay in the same position you pinch it. It's called tenting, right? So I let it go, mine goes right back. See? Everybody else should here too. Everybody try pinching themselves. Does it go right back to normal? Does it go back to normal though?
Cold can do that too, right?
It can, but with the heat patients, you want to look for that dehydration. So coating of the tongue, skin turgor are two signs of dehydration. Infants, okay, they can become dehydrated too, not just by heat, but heat can cause them to dehydrate, but also significant diarrhea and vomiting. Remember, they only have 500 mLs of fluid, so take your soda can, put it down. That's their total blood volume in their system, 500, roughly, right? So they can become very dehydrated. Infant dehydration, one of the biggest signs of infant dehydration is a sunken-in fontanelle. So you feel here, right? If it's indented like this, they're very dehydrated. Bulging out, increased cranial pressure, potential head trauma. Okay, two things to look at. We'll cover more of that in pediatrics, but again, look for that. Normal or slightly elevated body temperature on a rare occasion as high as 104 degrees. That's warm. Our bodies do not like 104. Our bodies don't like 101. We start seeing altered mental status sometimes at 103, 104 degrees. It starts becoming a little bit altered. Okay. Normal vital signs, although the pulse is often rapid and weak, the diastolic blood pressure may be low at times. The least common, more serious illness caused by heat exposure is heat stroke, which occurs when the body is subjected to more than it can handle at the normal mechanism for getting rid of the excess heat are overwhelmed. So you no longer produce sweat, right? So now we're redness of the skin, okay, which we'll talk about here in a second. Severe dehydration, hypotension, tachycardia, shock-like symptoms, right? Okay, on top of that, altered mental status. These patients are very critical. Patients can die from heat stroke, right? So untreated heat stroke will always result in death. Typical onset situations would be during vigorous physical activity, outdoor, or in a closed, poorly vented, humid space inside. During heat waves without sufficient air conditioning or poor ventilation, which we do even get up here. We do get heat waves of 90 plus degrees that can cause a lot of exhaustion, heat stroke issues. Children left unattended in a locked car or hot day. Has anybody ever done a training with that before at all? With a heat gun? How hot does it get inside those cars with windows closed? Do a heat, yeah. If you ever have a chance, if you see a car sitting there, nobody in it, hopefully, and you're in your fire apparatus, grab your heat gun really quick, or a thermal imager. Because that usually has the heat temperature readings in those, and all of them have that now. Okay, and look inside a car that's parked. But 100, like you said, 140, 150 degrees inside. Whether it could be 90 outdoors, but radiating through the glass and heating up the inside of the car. That's what's killing babies, killing kids, leaving them inside the vehicle. Dogs too, animals. All right. When I bring my dogs with me, we leave them in the car. We leave it running and lock the doors with the AC running inside, and put a note on the window saying, "Car is running, AC is on, dogs are fine. Please do not break window." All right, they're perfectly fine. They're happy dogs. It's nice and cool inside. So again, though, imagine being at 150 degrees with an infant. How long do you think they're going to last? Okay, ventilation is important. The signs and symptoms would be hot, dry, flushed skin, where the skin may be moist or wet due to exertion by the patient. Quickly rising body temperature, you've got to monitor that. Remember, also quick rising body temperature, especially in infants, can cause what? Seizures. Okay. Falling level of consciousness, change in behavior. Right. Patients unresponsive, need to maintain airway. You can ask Ron over there about airway maintaining. He had another one. Right, Ron? You get it. He gets a tube like every weekend. I don't get it. So, yes. Seizures, strong, rapid pulse at first, becoming weaker with falling blood pressure. Increased respiratory rate. Lack of perspiration. Our respiratory rate is going to start going up because why? Cool itself down, and also Fast, rapid breathing. What else will that do? And carbon dioxide, right? Which helps keep homeostasis in the body and it keeps you away from that acidic state. Okay. We don't want to keep that acid level down in our system. So our body's going to breathe faster. Also bringing more oxygen in. Heart rate goes faster to help circulate to the cells. Okay. But eventually that's going to stop. Your body's going to become too tired to do so. Right. These are all part of your body's mechanism to meet homeostasis, to reduce acidity in the system, oxygenate the cells better, and move blood around, right, through hemoglobin, have oxygen transport. If we can't have all of those, okay, what happens then? Our body shuts down, right? Shock. Our body requires 3 things to stay alive. What are they again? Sugar, oxygen, and blood. Without those 3, the body can't stay alive. So our body is going to start compensating. That's the tachycardia, all right, that we're going to see. It's compensating for that. It's like that with any type of shock. Our body has to compensate to meet homeostasis. If we can't do that, the body dies. That's when we have to come in and intervene, whether it be oral fluids, cooling down with cool packs, to warming up, to whatever it may be. We are going to be the initial, I don't want to say the word saviors, but that's what we're here for. We're here to help with that and help bring that body back to its normal level and getting ALS intervention and care. So seeing safety, perform an environmental assessment. The heat emergency may be secondary to a medical or traumatic emergency. So they could have had a medical event causing that patient to collapse then outside. So let's say they're outside working, they develop chest pain, right? They collapse to the ground. We get there and, oh, well, it's probably heat emergency. Get that 12, they're probably having a STEMI on the ground, right? Diabetic emergency, they're outside working, exerting, right? Sugars start to drop. They took insulin, didn't eat the right amount of food with the insulin. Their sugars drop down to a low level. Now they're hypoglycemic. They fall over, we get there. Remember I always told you, unresponsive, altered, anybody with cold exposures, even heat exposures like that, check a glucose. Even non-diabetics can be hypoglycemic. Okay, that can change based on the exertion, the energy being used, going from you burning that energy, burning to fat, and then reducing our blood sugars in our system. So check those on all of them. Consider calling ALS and look for other indicators of mechanism of injury. No different than a motor vehicle accident. If someone's unconscious in a vehicle, look for other signs and symptoms. Maybe their blood sugar is 10, right? I've had patients that have done that before and have driven miles upon miles based on memory, muscle memory, and have had blood sugars of 20. And eventually they crash, low impact. People that go off the road over a rock wall into a tree at 20 miles an hour should not be unresponsive in a vehicle based on mechanism, the way the cars are designed, seatbelts, airbags, and everything else. So find out why they crashed. It could be a low sugar, it could be a cardiac event, it could be a stroke. Okay. Look at your scene size up. See what you have. Absolutely. Hey guys online, I'm gonna take 5 minutes again. Sorry for the delay. We're gonna move trucks around in here.
This conference will now be recorded.
Yeah, we got a lot to go still. All right. We are back. Everybody back online? All right, so seeing safety, perform the environmental, look for I think we already covered this stuff here anyways, look for the indicators of MOI. If the patient is immersed in a cold water immersion bath, monitor the patient and assist as necessary. Protect yourself from the heat and stay hydrated and use appropriate standard precautions, including gloves, eye protection, gowns, whatever needs to be worn. Form a general impression, observe how the patient interacts with you and the environment. So what is their mental status? Looking at the AVPU scale, where do they sit? Ask them person, place, time, and event assessment. Introduce yourself and ask about the chief complaint. So why are we here? What is going on today? Could that be different, right? We could be there for a different reason. We could call for heat emergency and it's really not, okay? They could have chest pain, shortness of breath. Could it be a cardiac emergency? So assess the patient. Why are we here today? Oh, my legs are really cramping. Or they make absolutely no sense looking like they're having a stroke and it's a heat stroke issue. Perform a rapid scan and avoid tunnel vision. Like I mentioned before, just because they have a heat-related emergency does not mean something else didn't cause it. So don't get that tunnel vision. Look at your patient and treat them. Mental status, AVPU. So airway and breathing, unless the patient is unresponsive, the airway should be patent. Okay. Now, if there's a potential that they're going to vomit at all, then turn them on their side. Have suction ready. Nausea or vomiting may occur with this. So position the patient and protect their airway. Like I mentioned before, left lateral, right lateral recumbent, turn them on their side. So if they do happen to vomit, they're lying down, it comes out, it doesn't aspirate back into the lungs. If it aspirates back in, then we got bigger problems at that point, right? Lung infection, blockage of airway, right? We don't want that to happen. If consider spinal if needed. If unresponsive, insert an airway to provide bag valve mask ventilations. OPA first. If they gag, take it out. Then you put in an NPA instead, oral and nasal. We're going to be doing those today. So we're going to train you guys on the King and the Element, and the King and the eye gels, which are here for supraglottic airways. We're also going to do nasal oral airways, suctioning, oxygen administration as well. So all the airway stuff. Circulation, if adequate, assess for perfusion and bleeding. Assess the patient's skin condition, treat for shock. Major bleeding, control it. Okay. Next, investigate the chief complaint. So be alert for signs or symptoms and specific injuries. So absence of perspiration. If they're not sweating and they're hyperthermic, that's a bad thing. Decreased level of consciousness, confusion, muscle cramping, nausea, vomiting. So part of your chief complaint. Why are we called in? What is going on? Get your sample history and know any activities, conditions, or medications, like inadequate oral intake. Like how much have you been drinking today? Look at their medication list. If they're on any diuretics like Lasix, hydrochlorothiazide, something that's going to remove fluid from the body. The one thing about Lasix, if they're on, let's say they're on their water pill, they say, okay, keep in mind that Lasix is a non-potassium sparing diuretic, okay, which means you piss out your potassium and it doesn't replenish. Low potassium can cause cramping as well and cause cardiac arrhythmias, right? So if they're on Lasix and they're peeing and not rehydrating, they're going to start cramping up, right? Determine the exposure to heat and humidity and activities prior to the onset. All right, so look at medications the patient is on as well. Look at your physical exam. Assess the patient for muscle cramps or confusion. Examine the patient's mental status, vital signs. Get your baseline set and then repeat from there. Pay special attention to skin temperature. Skin turgor. Remember I mentioned before, skin turgor is pinching of the skin, white coating of the tongue, level of moisture in the system. Are you perspirating? Are you sweating? Perform a careful neurological exam. So do a stroke assessment. Does this feel different than this? Shrug your shoulders, checking accessory nerves. All right, can they move their shoulders up and down? Arms out, palms up, pronator drift. Close your eyes. Have them speak to you. Or their slurred speech. Any facial, have them smile. Repeat a sentence. You can't teach an old dog new tricks. That sentence I just told you about moves every muscle in the face. You'll be able to see them actually move and speak. All right. So do a full neuro assessment. Grip the hands. Are they equal on both sides? Same thing with the feet. Can you move the feet up and down? Can you do like this, back and forth? What they call a heel to shin rub. So you bring the heel to the bottom and you have them rub their heel out on their shin all the way up like this, right? Good neuro movements. Can you follow commands that I'm giving you? Vital signs. Patients who are hyperthermic will be tachycardic and tachypnic, right? Fast respirations, fast heart rate. Falling blood pressure indicates the patient is going into shock. Look at systolic, diastolic, and on your cardiac monitor, look at your MAP, your MAP, mean arterial pressure. Okay? You have to have a mean arterial pressure of 64 or greater to actually have perfusion. If it's less than 64, we're not perfusing appropriately. Those are patients that are very hypotensive. Our body has to have pressure to perfuse. 64 is your magic number. Less than 64, even in sepsis, patients are septic, they're hypovolemic, right? They don't have enough pressure in their system. You got to look at that number. Heat exhaustion and skin temperature may be normal or cool and clammy. In heat stroke, the skin is hot. You'll feel it. It'll be very, very warm. Okay. Now, if they're inside the house and they feel very, very warm, okay, it may not be a heat issue. It could be patient has a temp, an infection somewhere. Okay. So look at all the factors in your environments. If the house feels cool and they feel warm, their temp's 103, it's probably a fever from an infection, not a fever, not a high temp from an exposure. Watch for deterioration and reassessment. Patients can deteriorate fast, especially kids. They can compensate and then they decompensate quickly. Monitor vital signs for at least every 5 minutes. Evaluate the effectiveness of interventions and be careful not to overcool a patient and make them hypothermic. What we don't want is to go from sweating to shivering quickly. All right, we got to cool them down, not make them freeze. Communicate and document. Inform the staff that receive a facility early if your patient is experiencing a heat stroke. They have to know this stuff ahead of time. Patients in heat stroke may actually get intubated to protect their airway and cool the body down that way, potentially. All right. So you got to, they also have cooling blankets and everything else that they can utilize in intensive care units and all that. So again, let them know early so they can start preparing for it. Document and call for additional resources. You may need ALS provider. Management for heat cramps, remove the patients from the hot environment, loosen the clothing, high flow oxygen if indicated, rest the cramping muscles, replace fluids by mouth. Please do not give them caffeine. Soda's bad, right? Not for patients that are dehydrated like this, right? So water. And then a water spray or a mist. You have like a spray bottle. Heat stroke, move the patient out of the environment into the ambulance, set cooling the maximum. Administer high flow oxygen if needed and assist ventilations if needed. The owner's here, the building. Cover the patient with wet towels or sheets and aggressively fan the patient. Check a blood glucose level. Exclude other causes of altered mental status. So again, alcohol intoxication, stroke, things like that. Look at all those different things that it potentially could be. Notify the hospital and call for ALS if the patient begins to shiver. Call for advanced life support. One of the things that we can do is give a benzodiazepine to control the shivering. Okay, to kind of help with that. All right, drowning. Not going to touch on this very heavily. Water rescue programs do this throughout the entire program. So, process of experiencing respiratory impairment from a submersion or immersion in a liquid. What is the difference between a submersion and an immersion? What is the difference? Mm-hmm. Yes, that's it. Immersion, your body, your head has not gone underwater yet. So if you're in the water, head above water, it's called an immersion. Submersion is when your whole body's underwater at that point. That's the difference between the two for definition. Some agencies may still use the term near drowning to refer to a patient who survives after at least 24 hours after suffocation in water. Okay. The word near drowning, though, has kind of gone away. It's either you drowning victim or non-drowning victim. You're underwater, it's a drowning. You can come back from that within 24 hours. It's still the same, but near drowning is not there. Other things to look for as well with drowning, which is not as common, about maybe 10% of all drownings worldwide. You might have something called a secondary drowning or a dry drowning. You ever heard of that before? Anybody heard of that? So what is it? Say yes. I'm going to ask you what it is. What is? Yep. That's water intoxication. It's a little bit different though. This one here, when they inhale it, like you said, it goes down into the lungs and kind of sits in the lungs. So what happens is 45 minutes, hours later, kid playing in the water inhales water in the lungs. A couple hours later, 45 minutes later, sometimes 2 hours later, they lie down and all that fluid that's now concentrated load on the bottom of your lungs now distributes throughout the lungs and the alveoli. It can cause a patient to basically internally drown. Also, patients that have come out of the water and they've gotten back, let's say a drowning victim, you come out, you CPR, mouth to mouth, sorry, not mouth to mouth. Wow, I'm old, this is old school. BVM, the patient, fluid comes back out, patient wakes up. There's still fluid in the lungs, so they can have a secondary drowning later on, even in the emergency department. So we got to pay attention to them. They're, again, not super common. I've only had maybe 2 or 3 in 22 years. But again, you have to know that it does exist. Risk factors of drowning: alcohol consumption, pre-existing seizure disorders. I've had a couple drownings because of this. Geriatric patients with cardiovascular disease, unsupervised access to the water, laryngeal spasm. Inhaling water causes the muscles of the larynx and vocal cords to spasm and close up. Right? Air has to move back and forth, right, through the larynx. What's going to happen is that glottic opening, the opening here, it goes in, spasms and closes shut. Right? That doesn't allow for any more air movement to go through, and it stays spasmed. Okay? There's only a couple of ways to make that, fix that, and that's when if you paralyze the system, which you guys cannot do. All right. That's why it's so important when they teach this in water and ice rescue, when you go in the water, to cover your nose and mouth to prevent that torso reflex from getting water into your lungs. Okay. So submersion incidents may be complicated by spinal fractures and spinal cord injuries. Again, look at the mechanism. Was it diving? What was going on? Was it a diving injury? Then suspect spinal. Okay. Were they underwater and hit an object? We don't know. Was it a water ski tubing incident? Remember that if someone's on a tube or water ski and the boat makes a turn and they whip around, it's twice the speed of what the boat was going. That's how fast they're going on that tube. So if they're doing 30 miles an hour and they cut a corner and the tube cuts around like this, that's 60 miles an hour they're going roughly. Imagine falling off of that and hitting a wall, which is the water. It's not very giving when you hit, right? So you got to think mechanism of injury. And remember, they're not protected. All they have is a vest on, hopefully. All right. Is the patient unconscious? The patient complain of weakness, paralysis, or numbness, right? These patients here require boarding in the water, right? Not what we're going to do unless you're trained to do it. We don't go in the water and start backboarding people. It can be very dangerous for someone who's not trained and certified to do so. All right. It's not as easy as you think, for the most part. All right. So most spinal injuries and diving incidents affect the cervical spine. It comes in and they have hyperflexion, hyperextension. So they come in like this, they dive in. That's why I always say hands in front as you come in, right? And if you move your hands like this, it can maneuver you up and down in the water, right? So as you come in, if they do this like that, then they can have a head strike. And what's going to happen is they can have a compression, they can have a flexion, hyperflexion, or hyperextension. Okay, hyperflexion coming down, hyperextension coming back, and snap in the vertebrae. All right, because you can only go so far. If every one of you did this, and then someone else grab here and push down farther, you'll feel that hyperflexion. Right, so you got to be careful with that. Look for those spinal injuries, cervical immobilization. Okay. All right. So some safety stuff here. Water rescues are usually handled by specialized rescue personnel. There are NFPA codes that are out there. 1670 and 1006 are the two standards for technical rescue. And they break it down what level you're supposed to be at and what kind of training you need. Okay, that's 1670, 1006, two standards that are there. Reach, throw, and row, and then go rescue is last. That's what we always teach. Right? If I can reach out and yell to somebody, hey, can you swim in? Right? Can I reach out with a pike pole? Can I inflate a fire hose? What can I do? All of our ambulances, I got to put them on the trucks. We just bought throw bags for all of our ambulances because with the volunteer departments and we're us being staff, we can be on scene 10 minutes before someone else shows up. If I can take and throw something out to somebody to pull them in, absolutely. All right. We're also buying PFDs too, inflatables, so that they're for within 10 feet of shore. NFPA says you have to have a PFD on. Doesn't say what type. This has to be the PFD that can float in the water. So we're going to look at inflatable vests because we're going to be there first. And we want to make sure we can at least do something to at least help. We're not going to go in the water. That's not our deal. We're not trained for that. Even though most of us are already certified in it, but yes. Recovery techniques: if the patient is not floating or visible in the water, an organized rescue effort is necessary. Specialized personnel are required with snorkel, mask, scuba gear, things like that. Right? There's different types of rescues. There's dive rescue and recovery. Then we have surface water rescue, which we use in the lakes. Then we have swift water rescue, which we use for anything with moving water. Then we have ice rescue, which is obviously during the ice season. Right? So there's different levels, different training that you need to do this job. In order to go into the water, you're supposed to, by NFPA, you have to be a technician level certified. Okay. Anything less than technician, you're not allowed to go in the water. Operations allows you, if your operational allows you to do boat rescue stuff and things like that, but you can't be that dope on the rope. That's what we call them. You can't go into the water and actually perform that rescue unless you're a tech. Resuscitation efforts: never give up on resuscitating a cold water drowning victim. They're not dead until you're warm and dead. Warm them up. Hypothermia can protect vital organs from the lack of oxygen. That is called mammalian diving reflex. Okay. The diving reflex may cause immediate bradycardia. Okay. Heart rates 20, 30. Okay. And that's okay. That's Mother Nature's way of shutting your body down. It's called the mammalian diving reflex, or the diving reflex. Slowing of the heart rate caused by submersion in cold water. Descent emergencies caused by a sudden increase in pressure as the person dives deeper into the water. Typical areas affected: lungs, sinus cavities, middle of the ear, teeth, face. And we'll talk about the bends here in a second. Coming back up too fast without taking your interval breaks that you need to have based upon how deep you go and how long you're underwater for. Are you dive certified at all yet? You are? Right. I've never gone through a diving class. I know a little bit about it. If you want to talk about it, you're more than welcome to. Anybody else dive certified at all? So it's a whole different world coming back up. You can't just go down 100 feet and then right back up again, right? So, and if you're underwater for like, let's say, an hour and a half, you can't just come back up to the surface too fast. Yep. Yep. Yes. So we haven't gotten into this yet, but we will. But something called the nitrogen he's talking about is called nitrogen narcosis, and it makes you a little loopy, but it can also kill you. You can also have extreme pain, especially in the joints, like your knees, your elbows, things like that too. And we have nothing around here to treat that. What do you need? Chamber, right? Hyperbaric chamber. Now, a lot of hospitals have them, but they're used for wound care. They're not big enough to take a full patient like this for it. So your closest one, I mean, I think Boston is the closest one. They have them for wound care though. I don't think so. The big chambers that you go to inside the hospitals. UNH used to have them at the college, but they got rid of them. They're done. They shut those down. So I know that like 6 years ago, there was a major CO incident in Manchester. They had like 8 people unresponsive, and everybody got intubated and had to be transferred down to Boston. That was the closest hyperbaric chamber to Manchester at the time. So learn where your closest ones are, really. And then the thing is can we fly them? You got to be careful because now you're going elevation and height even more. So you got to watch out what you do. But a lot of times, rapid transport, getting them to a hyperbaric chamber, so they can bring them back down to that level and they can work their way back up again. All right, they bring it back down to the pressure that you were at. So again, it affects all these areas. Just be aware. And we do have lakes deep enough. I don't know the deepest part of Winnipesaukee. I don't remember. Yes. So, but I'm not sure what the deepest is though in Winnipeg. I think it's deep. I can't remember the actual depth. So But there are a lot of places that have 96 to 100 foot, you know. So again, what was that? 212 feet deep as part of Winnipesaukee. That's deep. It's a long way down, especially for a lake around here. So again, we may have diving incidents that we may respond to. They're not as common. Usually people have experience and know what to do, but there are some that just panic and they come right back up again. You're like, what are you doing? Get back, you know. All right, so the pain forces the diver to return to the surface to equalize the pressure. And the problem clears up by itself for descent emergencies. So perforated tympanic membranes. So cold water may enter the middle ear through a ruptured eardrum. And so the diver may also lose his or her balance, shoot to the surface, and then run into ascent problems. Right? So they have that tympanic membrane rupture and they go back up quickly to try to see if they can fix it. And they can't. You still got to come back up and take your time. Going back up your 10-foot intervals, like Taylor was saying, 10-foot, 10-foot. You wait, what is it, like 10 minutes or so? 5-10 minutes? Yeah. Right. Yep. So everything's all timed when you're down there as well. So they know how fast they have to come back up and where they have to, for their stops. Which means you need to plan out your whole entire attack because you only have a certain amount of air in your tanks. You don't want to run out. You guys carry spare air as well, just in case? Yeah. 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 Your ascent from there. Yep. Good policies to have in place. Not a lot of fire departments have dive teams anymore. They're too dangerous, or they have lack of personnel that want to do it. So that's awesome that you guys are getting that, bringing that back. Yeah, that's good. So emergencies at the bottom, which rarely occur, caused by faulty connections in the dive gear, inadequate mixing of carbon dioxide and oxygen in the air that the diver breathes, accidental feeding of poisonous carbon monoxide into the system itself can cause a drowning or rapid ascent. Require emergency resuscitation and transport when we get up top. So again, just be ready for it. Usually requires aggressive resuscitation for ascent emergencies with an air embolus. Most dangerous and most common scuba diving emergency, where air bubbles of the air enter the blood vessels, and then they cause an air embolus somewhere. So air pressure in the lungs remain at the high level while pressure on the chest decreases. Yes, right. So basically, the problem starts when the diver holds his or her breath during a rapid ascent. The air pressure in the lungs remain at the high level while the external pressures of the chest decrease, and the air inside the lungs expand rapidly, causing the alveoli in the lungs to rupture. So we have alveolar rupture and collapse. So some of the complications: air may enter the pleural space and compress the lungs, which would cause a pneumothorax. Air may also enter the mediastinum, which is the space within the thorax that contains the heart and great vessels, causing a condition called the pneumomediastinum. I've seen a couple of those, but not from diving injuries. I've seen those in the emergency department. I've transported them before. They had air build up in here. Air may enter the bloodstream and create bubbles of air in the vessels called an emboli. The signs and symptoms of the embolus would be blotching or mottling of the skin, froth or often pink or bloody sputum coming from the nose and mouth, severe pain in the muscles, joints, and abdomen, which I talked about before, building up severe pain through all the joints. Dyspnea or chest pain, dizziness, nausea, vomiting, dysphagia or difficulty speaking, cough, cyanosis, difficulty with vision, paralysis, or coma, irregular pulse, and even cardiac arrests. So who wants to go diving? Anybody? Decompression sickness, which is called the bends, where bubbles of gas, especially nitrogen, obstruct the blood vessels, a condition that causes decompression sickness. Too rapid of an ascent from a dive too long a dive at too deep a depth, and repeated dives within a short period of time. So driving a car up a mountain or flying an unpressurized airplane that climbs too rapidly soon after a dive will also cause this as well. So don't go down for doing diving and decide to go on a flight down to Florida later. Nitrogen that is being breathed dissolves in the blood and tissues. That's what they call nitrogen narcosis, which literally makes you crazy. You have that buildup of nitrogen in your system. The diver extends that an external pressure is decreased or dissolved nitrogen forms small air bubbles within the tissues itself. Like Taylor said, it will kill you. Complications will be blockages of tiny blood vessels, depriving parts of the body from their normal blood supply. Severe pain in certain tissues or spaces. Signs and symptoms would include abdominal joint pain, so severe that the patient doubles up and bends. So they call it the bends because it hurts so bad. There's so much pain. All right. So you may find it difficult to distinguish between air embolus and decompression sickness. An air embolus generally occurs immediately on return to the surface, where decompression sickness may not occur for several hours. Okay. So again, if you see instantaneous, as soon as they return to the surface with issues, that's going to be your air embolus. Decompression sickness hours later. Okay, they're perfectly fine to get out, and then they start getting sick later on. So these are your treatments: basic life support and recompression in a hyperbaric chamber. Like I said, they usually bring you back down to the depth you dove in, and they bring you back up in levels, right? But even still, you can die in these things, and there's no way to get inside and even treat you. Once you're in, right? You don't come back out until you've gone back through the process to help decompress your system. Hmm? Right. This patient needs to go back down and recompress. Do you guys go through any decompression training at all? Or when you guys do your dive school? That's it. Yeah. There's a number you can call as well. It's called the Dan Network. You heard of that before? The Dan Network out of Florida. It's a publicized number anybody can call from any state. And they specialize in dive emergencies, and they can talk you through. It's kind of like calling poison control. It's called the Dan Network, DAN. So you should have that number programmed in your phone, especially if you work in like a lakes region area with diving. Now, if you work up here in Madison, you're not going to work over in Wolfboro around the lake, you probably don't need it. But the Dan Network, especially if you're an EMS provider in a lakes region or by the ocean or things like that, you should have that number in your phone. It definitely can be beneficial to give them a call and say, "Hey, I got this. What do I need to do?" It's basically like calling poison control, but for dive emergencies. So, scene safety, glove, eye protection. Never drive through moving water. So be cautious driving through still water. Don't drive through a lot of water, okay? Especially moving water. It doesn't take much to get a vehicle to float, right? 6 mile an hour water is like 512 pounds of pressure against you. 6 mile an hour water, that's not fast at all, right? 12 mile an hour pretty much doubles and then more, right? So swift water can move a vehicle, even fire trucks, even ambulances, so don't drive through them. Now, if it's a puddle, yeah, whatever, right? But if you start driving in and the water's going up to the top of your wheels, you probably should back out, especially if you stall in the middle of it. That'd be pretty embarrassing, right? Never attempt a water rescue without proper training and equipment. Consider trauma and spinal mobilization and check for additional patients as well, right? You guys go to my trail, you'll see a lot of water equipment in there. There's a lot of stuff in that trailer outside. Form a general impression, so pay attention to the chest pain, dyspnea, and complaints of sensory changes. Determine level of consciousness using the ABPU scale. Be suspicious of drug or alcohol use, and maintain and open an airway. All right. If you can't open an airway, you need to open it up, suction out, whatever it be, ventilate for the patient if they're not breathing. Call for ALS if you need to make an airway. Consider spinal. Take appropriate action. Suction if the patient has vomited. Clear that airway out. Remember, when you go in, there's be something on your test today, on your test stations. Suction only on the way out. no more than 10 to 15 seconds coming out in circular motion. Then go back in again and suction on the way out. Provide ventilations by a VVM. If the patient is responsive, provide high flow oxygen with a non-rebreather mask. So we'll show you guys how to use those today as well. Auscultate breath sounds. Try to get this done before. It may be difficult to find a pulse. So again, if the pulse is unmeasurable, the patient may be in cardiac arrest. If you think you feel it, but you're not sure or no pulse at all, start CPR. You're better off giving somebody CPR that has a pulse than withholding it from someone that does not. So start CPR. Evaluate for shock. If the MOI suggests trauma, assess for bleeding and treat appropriately. And then always transport near drowning patients to the hospital. Inhalation of any amount of fluid can lead to delayed complications. That's your secondary or dry drowning we talked about. Decompression sickness and air embolus must be treated in a recompression chamber. So find out how we're going to get them there. All right. Contact med control. Tell me of a decompression issue, and then notify DART so they can come down and get the patient. Okay. But still, don't wait for DART on a site. Bring them to the hospital because DART can always divert. They can always not cancel the response because of whether something could change. The last thing you want is to be 45 minutes away from a hospital, waiting for a helicopter, and then saying, "Sorry, we had to abort the mission because of mechanical failure." And you're like, "Oh crap, 45 minutes away." Start working towards a hospital. Utilize the hospital's helipad as a landing zone. Over there, if they happen to abort the mission, you just unload and go into the ER. All right. So use Memorial, use Huggins from around here, use their landing zones, and they're already pre-done. You don't have to anybody set anything up, right? You land in a field, fire's got to go there. Another agency has to be dispatched. You have to set up the landing the coordinates, get the GPS coordinates and all that for the helicopter. Unless you have them pre-done, some towns have services have them pre-done in the area with numbers already. They've already submitted to DART and Life Flight and all that, or dispatch. But hospitals are already pre-done, right? So go with those. Perform all interventions en route. History taking in your sample history. Other questions you want to ask: depth of the dive, length the patient was underwater for, time of onset of symptoms, and any previous diving activity. Note any physical activity, drugs, alcohol, or any other medical conditions that are present there. Examine the lungs and breath sounds. Get a good set of lung sounds. Listen to them. Look for hidden life threats and trauma indications of the bends, air embolus, signs of hypothermia. Complete a full detailed body scan en route to the hospital. Peripheral pulses, assess for those. Skin color, discoloration, itching, pain, paresthesia, or numbness and tingling. Check your vital signs. Remember rate, rhythm, and quality for respiratory rate, heart rate, things like that. Rate, rhythm, quality for all of those. Assess pupil size and reactivity. This is going to help us with any kind of potential brain injury. Oxygen saturation readings may be inadequate for this. Okay. So use your other signs and symptoms. End tidal CO2. Monitor carbon dioxide off-gassing. Monitor the respiratory rate with that. Put on the nasal prongs. Look like your end tidal. Repeat the primary assessment. Drowning patients may deteriorate rapidly due to pulmonary injury, fluid shift in the body, cerebral hypoxia or hypothermia. Pneumothorax, air embolus, or decompression sickness patients may decompensate very quickly. So look at your signs and symptoms that are there and say, is this what it is? This decompression sickness? Is it a pulmonary embolus or air embolus? What are the signs and symptoms that are there, and how fast are you going to get them to the hospital?
Have you seen those hyperbaric chambers that they take on high altitude expeditions? It's like it almost looks like a pontoon. It's like same thing that a inflatable boat is made out of.
Yeah.
And they fill up with a foot pump.
Interesting. That's pretty cool. Wouldn't that be something to be able to get one of those and do that for a diving injury and start them right off the bat and put them in an ambulance and transport it? That'd be kind of neat. I don't know how well they'd work for that. So we weren't doing research topics in this class. It'd be a good one for you. I used to do essays for my EMT students. It was worth 10% of their grade. I stopped doing that though. Let's see. So circumstances of drowning and extrication. You need to document that. How long they were under for submersion, temperature and clarity of the water. Is there any possible spinal injury? Bring the dive log or dive computer. Have that information as well, and bring all dive equipment to the hospital. We're going to mobilize and protect the patient's spine if a fall or diving injury is possible. Think it's an injury? Mobilize. We are not, as EMTs, are not trained to go into the water and do spinal mobilization, right? That's a separate class, separate training through a technician level course or a lifeguarding course. Perform chest compressions using AED if indicated, and treat for hypothermia. For air embolus and decompression sickness in a conscious patient, remove the patient from the water, try to keep the patient calm, administer oxygen, consider the possibility of pneumothorax and monitor breath sounds, provide prompt transport. Other water hazards, you pay close attention to the body temperature of the person who is rescued from cold water. Core temps are really key for these patients to actually get a true body temp. Persons swimming in shallow water may experience a loss of consciousness caused by a decreased stimulus for breathing. So treatment is the same as a drowning patient with these. Other ones would be shallow water blackout, or what they call hyperventilation syndrome, where they hyperventilate to stay underwater for a long period of time. Okay? And this could cause the patient to have a syncopal episode and pass out and start the drowning process underwater. Prevention, appropriate precautions to prevent most immersion incidents. So all pools should be surrounded by a fence. These are what they call isolation of protection or layers of protection. And these are all part of that. So pools being fenced. The most common problem in child drowning is the lack of adult supervision, right? So they go to the beach, they fall asleep, let the kid just run and play, not supervised. Half of all teenagers and adult drownings are associated with the use of alcohol. Gates opening the wrong direction, right? Gates should open outward with a lock behind the gate. Okay, that's actually laws now behind that. Because what do kids do? They push. They don't know how to pull. They don't understand it, right? So they want to push to get in, and you want to have, there's actually measurements too as well. I want to say it's like 4 feet up and behind the backside where a kid can't reach around and pull the tab up to get in, right? Water alarms, water motion alarms are phenomenal. They actually make those. And you move into the water, sets off an alarm for indoor pools. There's so many mechanisms and things that are out there. 2 drains required in every swimming pool now. Yep, they're required. So any new pool that's built required to have 2 drains. So that way there, if one gets clogged by someone's hair, jewelry, extremities, or whatever, the other one can still flow through and they don't actually get stuck anymore. They're also required to make sure that they actually check the caps in the bottom for how brittle they are, because they can easily break. Hot tubs are now required to have 2. There's been some incidents, and I have videos where kids have sat down on them and it sucked out their intestines through their anus. Right? It takes greater than almost 500 pounds of pressure to pull something out of a drain hole if the suction is still on. They did a test and they put one of those mornings that are out there in the water. They put it inside. It's sucked in. They took a crank with a pressure gauge on it, and they're cranking it. It finally released after 500 pounds. Can any one of us do that in this room? Potentially lift 500-pound deadlift of a kid, right? Okay, and if you could, what things would happen to that kid when you're pulling him up, right? Pool alarms and shutoffs now have to be in that pool area now. They no longer can be behind locked gates like they used to be back in the day. Once they shut it off, right up, no issues at all. They had 2 guys trying to do a deadlift on that ball that morning that was in the water. Couldn't move it. It just bent a little bit. They couldn't lift it up out of it. So again, prevention is key. And a lot of laws have changed. I say pretty thorough with the Drowning Alliance stuff because of the water classes I teach all the time. So this is pretty important stuff. Prevention. Dysbarism injuries caused by difference between the surrounding atmospheric pressure and the total gas pressure in the body for high altitude stuff. Altitude illness, which we were just talking about a little bit here with that interesting chamber I want to look more into. So affects the central nervous system and pulmonary system as well. Okay. Acute mountain sickness is diminished oxygen in the blood caused by ascending too high, too fast, or not being acclimated with high altitudes. Signs and symptoms be headache, lightheadedness, and fatigue. So a lot of times people bring oxygen bottles with them to help with that high altitude stuff until their body can acclimate. Because remember, it's a lower oxygen level up the higher you go. Acute mountain sickness, other signs and symptoms be loss of appetite, nausea, difficulty speaking, swollen face, shortness of breath during physical exertion. And the treatment primarily consists of stopping the ascent and descending to a lower altitude until you can work your way back up again. If you start noticing those changes, go back down. Then you have to go back up again once you start picking up and start acclimating to the area. What they call HAPE, high altitude pulmonary edema, which is fluid collection in the lungs, hindering the passage of oxygen in the bloodstream. So we already know about pulmonary edema, right? You talk about respiratory and cardiac stuff, right? So we have fluid buildup in the lungs and the alveoli, so we can't have good circulation. This is what's happening here. Shortness of breath, cough with pink sputum, cyanosis, rapid pulse. It's no different than acute coronary syndrome causing pulmonary edema. It's kind of like the same thing. Some high altitude is causing this, filling the lungs full of fluid. Almost done. High altitude cerebral edema, HACE, may accompany HAPE and quickly become life-threatening. So cerebral edema, so fluid buildup in the brain. Severe constant throbbing headache, ataxia, extreme fatigue, vomiting, and loss of consciousness. So lack of muscle coordination or balance. Yeah, I had to go back to it for a minute. So lack of coordination, muscle coordination or balance, or extreme fatigue, vomiting, loss of consciousness. So treatment for HAPE and or HACE is providing oxygen. You got to bring them back down levels, so descent from a height. Transport properly and provide positive pressure ventilation with a back valve mask for inadequate respiration. So if they're not breathing right, we got to breathe for them. So BVM is not just used for the unconscious, not breathing patient. If they are breathing too fast or too slow, we can help control that with a BVM. All right, lightning is the third most common cause of death from isolated environmental phenomenon that are there. Targets direct lightning strikes. People engaged in outdoor activities, boaters, swimmers, golfers, anyone in a large open area. Right? Lightning has to come in and it has to find an exit point. Okay? So we're going to see burns as well as cardiac dysrhythmias as well. Many individuals indirectly struck when standing near an object that has been struck by lightning, such as a tree. They'll be able to feel the energy from that. The cardiovascular and nervous system are most commonly injured. Respiratory or cardiac arrest is the most common cause of lightning-related deaths. When I did my intermediate test in 2006, I had 15 questions on my written exam, paper exam, by the way, not computer, on lightning strikes. Don't know why, but 15 questions on lightning strikes. I'm like, really? You know? But again, third common cause. Categories of lightning injuries would be mild, loss of consciousness, amnesia, confusion, tingling, superficial burns, to moderate, seizure, respiratory arrest, dysrhythmias, or superficial burns, and severe would be called cardiopulmonary arrest. Sanford Dispatch, back in the day when it was York County and Alfred, there were dispatchers that were on the phones and the building got struck by lightning. It knocked the dispatchers out of their chair. It came through the phone lines into their ears and threw them out of their chairs. One of them went on workers' comp for about a year because it knocked off her equilibrium for about a year before she could go back to work. Through a phone line. You don't. It's just a rare occurrence, but it happens. So again, struck lightning, struck the tower. The radio towers came through the system and right back through, found her on the phone like this, and literally threw her out of her chair. So much power there was behind it. Interesting, right? Yeah, I don't know. All right, spider bites. Spiders are numerous and widespread throughout the U.S. Many species of spiders that are out there. Only the female black widow spider and the brown recluse spider deliver serious and life-threatening bites. So be alert for the possibility that the spider may still be in the area. I've seen brown recluse throughout Maine, New Hampshire, right? I have not seen any black widows though. But this right here is the black widow spider, and you can tell by the red spot on the back that is there. The female is fairly large, measuring approximately 2 inches across. It's a big spider, too big for me. Usually black with a distinctive bright red orange marking in the shape of an hourglass on its abdomen. I'm sorry, at the back. The female is larger and more toxic than the male. Probably. They're found in every state except Alaska. They prefer dry, dim places. I guess they are. Most bites cause localized pain and symptoms, including agonizing muscle spasms. If the site becomes numb right away, the patient may not even recall being bit. However, the black widow spider bites cause localized pain and symptoms. A bite on the abdomen may cause muscle spasms so severe that they may resemble an acute abdominal condition. The main danger in the venom is the venom, which can damage nerve tissues. Other systemic symptoms include dizziness, sweating, nausea, vomiting, rashes, tightness in the chest, and severe cramping. Generally, these symptoms subside over 48 hours. Treatment consists of BLS for the patient and respiratory distress, and then transport as soon as possible. The physician can administer a specific antivenom, but because of its high incidence and side effects, is usually reserved for very serious bites, the aged or very feeble, or children under the age of 5. This is a brown recluse spider, dull brown in color, about 1 inch long. The violin-shaped mark on its back, which is kind of hard to see in the picture here. It was mostly in southern and central parts of the country, sorry, but can be found through the continental United States. Tends to live in dark areas as well. The venom is neurotoxic, but cytotoxic as well, and can cause severe local tissue damage. Typically, the bite is not painful at first, but becomes so within hours, and the area becomes swollen, tender, developing a pale, mottled cyanotic center. You want to transport these patients with such symptoms as soon as possible. All right. Stings, bees, wasps, yellow jackets, ants. Stings are all painful, but are not a medical emergency for these. However, anaphylaxis is. So the sting itself is usually not an issue. It's whether or not you're allergic to the sting. So anaphylaxis may occur in a patient with allergic reaction to the venom. So remove the stinger and the venom sac using a firmed edge, such as a credit card, to scrape the stinger and sac off the skin. So take a credit card, rub it on the skin like this here, and just kind of scrape it off. You don't want to pick it off. You don't want to rub it off with your finger because you can inject yourself potentially, right? So this credit card, whatever, just scrape it off. So you want to look for stingers. If you have someone that got stung multiple times, look for the stinger and see if it broke off anywhere. And then start checking for urticaria, which is rash, hives, right? So you need to expose your patient, okay? Because if they got stung down here in the leg, they have a localized reaction. Are they breaking out with hives up on the chest and the back? And if you don't pull up their shirt to look, you're going to miss it, right? If the patient is having an anaphylactic reaction, be prepared to administer an EpiPen or a ready check inject kit, which is what we carry up here. EpiPens are too expensive, so you drop your own Epi. That's 0.3 milligrams for adult, 0.15 for pediatric.
Yes, start making EpiPens really cheap.
Not sure. We don't buy them. We just put the ready check inject in because it only costs us like 15 cents to buy the Epi. So it's called or an adrenaline vial. Snake bites. There are approximately 115 different species of snakes in the U.S. Only 19 are venomous. Rattlesnake, copperhead, cottonmouth, or water moccasin, and coral snakes. At least one of these poisonous species are found in every state except Alaska, Hawaii, and Maine. So it says down here, Maine is one of them.
One that looks like a rattlesnake.
I've seen copperheads en masse on Cape Cod. We saw them quite often.
The snake I've seen looks just like a coral snake, except it's got the
Yeah,
inverted color.
interesting. Here's some snakes here. So, couldn't tell you A, B, C, or D, but rattlesnake, copperhead, cottonmouth, and water moccasin, and a coral snake. What you're seeing here in the photos. I am not a snake expert. If I see a snake, I just don't go near it. That's it. Start throwing things at it. If it's really big, I'm not going anywhere near you. Snakes usually do not bite unless provoked, angered, or accidentally injured. Like you step on one by accident, it'll come around and start and bite you. Protect yourself. Wear proper PPE. The classic appearance of a poisonous snake bite are two small puncture wounds with discoloration, swelling, and pain. So as you can see looking at the snake here, rattlesnakes, copperheads, and cottonmouths are all pit viper with triangular shaped flat heads. The small pits that contain poison located just behind each nostril and the front of the eyes. You can see over here. The venomous sac sits here, it comes out through the fangs, and you get injected. All right. So rattlesnakes are a more common form of pit viper. Many patterns and colors, diamond pattern, and can grow up to 6 feet or longer. But usually they spring from the rattling sound as you get closer, saying, "Hey, this is my area, back off." Copperheads are usually 2 to 3 feet long. They have a red copper color crossed with a brown and red band. If you see those, stay away. Their bites are almost never fatal, but the venom can cause significant damage to the extremities and cause a lot of necrosis of the tissue that's there. Cottonmouths are olive brown with a black cross band and a yellow undersurface. Water snakes are with aggressive behavior, and tissue destruction may be severe with this. Signs of envenomation would be severe burning, pain at the site of the injury, swelling, bluish discoloration, weakness, nausea, vomiting, sweating, seizures, and fainting. Signs are evident within 10 to 15 minutes and spread over the next 36 hours as well. Other ones would be vision problems, change in level of consciousness, and shock. If the patient has no local signs after an hour being bitten, it is safe to assume that the envenomation did not take place. Okay, so within the hour. Treatment for this would be calm the patient. I know you just got bit. Just relax. We're good. Place in a supine position. Locate the area bite and clean it gently with soap and water. Be alert for anaphylactic reaction and treat with epinephrine auto-injector as appropriate. Do not give anything by mouth and be alert for vomiting. Consider the use of a pressure mobilization bandage of the extremity and then place the affected extremity below the heart. You don't want to elevate it because then that toxin can go in. So below the heart, right? So you may not be able to put a patient fully on a stretcher because the leg bite, which most likely that's where it's going to be, is kind of dangle it over the edge. Apply pressure bandaging to it and transport. If the bite occurred on the trunk, keep the patient supine and quiet and transport as quickly as possible. Sir, please stop talking. If there are any signs of shock, treat it. If the snake has been killed, bring it with you. Notify the hospital that you're bringing in a patient with a snake bite and transport promptly. All right. So quick, I know we got to break for lunch here. We're running out of time, but we had a patient at Maine Medical Center that came in. I was working as a BLS provider on a medic unit, and it was a poison. I remember the snake. This was like 15 years ago. There was a poisonous snake at home. The guy had at home as a pet. It bit him. Really, really sick. The closest anti-venom was New York City. I had to do an emergency stat transfer from Maine Med to New York. Now, Miami-Dade Fire Rescue, you ever watched that snake response thing? Have you seen that before? Miami-Dade Fire Rescue actually has a response unit called, I think it's called Venom 1. I think that's what they call it, Venom 1. And they respond to hospitals with anti-venom down there. Because they get so many snake bites down that area. So they had a TV show about it for a while. I think it was called Venom 1. It responded out. Yeah, it would go from this major hospital. It was part of Miami-Dade Fire Rescue. There was a specific unit just to transport anti-venom from a hospital. So we don't have that up here. Like I said, New York City was the closest anti-venom for this patient. He was going to die if he didn't get it. We had to drive him down because there was a snowstorm that day. Of course, it was like about an 8-hour drive for me to get down there. Yeah. So coral snakes, small reptile with a series of bright red, yellow, and black bands completely encircling the body, lives in most southern states, which injects venom with its teeth and tiny fangs by chewing motion, leaving puncture wounds. Usually bites a victim on the fingers or toes. They'll get you, for shoes. Coral snake venom is a powerful toxin that causes paralysis of the nervous system. Within a few hours of being bitten, a patient will exhibit bizarre behavior followed by progressive paralysis of eye movements and respiration. Anti-venom is available, but most hospitals do not stock it. So, emergency care is the same for a pit viper bite. There's no changes.
Scarlet king snake is the one that lives in Maine, just like the coral snake. Basically, just the opposite coloration.
So scorpions are 8-legged arachnids with venomous glands and a stinger at the end of the tail. They are rare and live primarily in the southwestern United States and in deserts. With one exception, the scorpion sting usually is very painful but not dangerous. Yeah, I'm good. So I don't want to be stung by one. All right. Let's see. Venomous may cause centroideus, whatever. I don't know, pronounce that word. Let's go with it. All right. Circulatory collapse. The venom may cause circulatory collapse, severe muscle contractions, excessive salivation, hypertension, and convulsions and cardiac failure. The reason why I like living in New England. All right. Tick bites. All right. We know a lot about tick bites. Please do not brush them off. Make sure you get the head and everything that comes out. It's the Lone Star tick, the one I don't want to get bit by. You guys have heard about that one, right? You heard about the Lone Star tick? Allergic to meat? Yeah, I'm good. You'll never be able to eat meat. You'll never be able to eat meat again. Instant vegetarian. All over. They're starting to find them more in New England now. A tick that makes you allergic to meat. I have no idea. It's something. It's a newer tick that's out there. It's been around for what, maybe 5 years now or so. Yep. So remember, there's other ticks that are out there. It was more to Texas than where it came from, didn't it? Yeah, it came from Texas and it's worked its way up. Deer ticks, Lyme disease. Okay, so again, tick bites are usually not painful, but the danger of the tick bite is from its infectious disease spread through the skin, tick saliva, as you can see here. Yep. Yeah, it's just, remember that. Yep. So Rocky Mountain spotted fever occurs within 7 to 10 days after a bite. Symptoms include nausea, vomiting, headache, paralysis, weakness, and cardiorespiratory collapse. Lyme disease reported in all states except Hawaii. Seems like Alaska and Hawaii are the two states like really live in. The first symptoms are generally fever and flu-like symptoms, sometimes associated with a bullseye red rash that may spread to several parts of the body. Painful swelling of joints occur and may be confused with rheumatoid arthritis. And that's a specific test. Yep. Yeah. And this here is only detected through blood tests. So they do a line, and actually, if they run a normal panel, you're not going to get that test done. It's a specific test called a Lyme test they have to do. So it's a specific order for nursing and things like that. They have to put in a specific order to be able to test it. I screwed that up once and I clicked it off. I checked off the wrong box and it came back positive. Patient had no idea. The doc's like, why did we order this? He goes, but I'm glad you did because it came back positive. I was like, huh. Not even in there for signs and symptoms at all for Lyme disease. I clicked the wrong box when I did the order. It came back positive. Patient had no idea. So interesting. All right. So tick bites occur most commonly during the summer months. If transport will be delayed, remove the tick by using fine tweezers or grasp the head and pull it straight out. They make tick removal kits that look like almost like a little scoop with a V shape like this on it, and it comes in and you pop the head right out with it. Yep. Yep. Yeah. I have my wife has one on her keychain for the dogs and all that, and for us too if we need it. But once the tick is removed, put the tick in a bag, cup, whatever, and bring it with you so they can test it and see what kind of tick it is as well, to be able to treat it. All right, injuries from marine animals. This should be the last of it here. And I have a plan for today, by the way, because this is kind of going longer than I had planned on being. And there's a lot of practical stuff, so I may move CPR to another Sunday, which will be easier. If you do more time on a patient assessment. And there's some people that are not here today that still need CPR. So maybe we'll just move it to a different day, different Sunday that we're doing. Better. So you don't have to sit here and do more class time. So obviously with marine animals, you don't have to deal with a lot of that here, but the ocean communities do. So fine coral, Portuguese man of war, sea wasp, sea nettles, true jellyfish, sea anemones, true coral, and soft coral are some different things we have to kind of understand. As you can see here, like jellyfish and things like that, and man of wars. Be careful in the southern states because a lot of these Portuguese man of wars and jellyfish are coming more inshore now, because there's something called a spider crabs. I think of the name of it. Don't ask how I know this stuff. It's weird. Spider crabs attached to jellyfish because they can't grab anything because they have like spider ends, like they don't have claws like that. They have the two that come out, and they attach to jellyfish to catch rides in from the ocean into shore. But then the jellyfish get washed up on shore and they can still sting you and they can't get back in. And they're dying. They dry out and die. But interesting stuff. So jellyfish stings. Okay, painful. What's one way to get rid of the sting? You pee on them. I'm not saying that you need to squat down or take out and pee on your patient, right? This is going to get a little uncomfortable, but some of your oceanside community services carry vinegar and spray bottle, and they spray it over the site, and that neutralizes this thing. Vinegar in a spray bottle. Like all the Portland ambulances, MedQ, they carry bottles of vinegar for jellyfish stings. Ouch. Yeah, neutralizes it. Very painful reddish lesions in light-skinned individuals. Headache, dizziness, muscle cramps, and fainting. Some signs and symptoms for marine animal stuff here. Emergency treatment, limit further discharge. What is it? Nematocystis. By avoiding fresh water, wet sand, showers, or careless manipulation of the tentacles. Keep the patient calm. I know you got stung by a jellyfish. I'm going to pee on you soon, but stay calm. Reduce the motion of the affected extremity. Remove the remaining tentacles by scraping them off with a sharp edge, kind of like credit cards with bee stings. Provide transport to the emergency department. All right. So again, but yeah, vinegar will neutralize it. So vinegar spray bottles work pretty well. Now, we don't need to carry those around here. We're not anywhere near an ocean, but the ocean communities, if you're working in one, be familiar with how to treat jellyfish stings. That's a very, very common. A lot of people get them. All right. So when a person is exposed to the cold temperature and strong winds for an extended period of time, he or she will lose heat mostly by. You guys can't push the buttons in chat. You got to tell me what they are here. Am I good right here? Can you guys see? I'm back down. Yep. Convection. Feel free to jump in online too with your answers. Yes, the answer is B. Shivering in the presence of hypothermia indicates that. Nice. Good job. C it is. Number 3, all the following are examples of passive rewarming techniques except. B it is. Good job. You're paying attention today. We should do more classes in person. All right. A woman has frostbite in both her feet after walking several miles in a frozen field. Her feet are white, hard, and cold to the touch. Treatment of the scene should include. All right. D it is. Number 5, a 30-year-old male who has been playing softball all day in a hot environment complains of weakness and nausea shortly after experiencing a syncopical episode. Appropriate treatment for this patient includes all the following except. It is. Number 6, you are assessing a 27-year-old woman with a heat-related emergency. Her skin is flushed, hot, and moist, and the level of consciousness is decreased. After moving her to a cool environment, managing her airway, and administering oxygen, you should do what next? What you guys got? C's and D's? All right, C it is. That's okay. Number 7, it is important to remove a drowning victim from the water before laryngeal spasm relaxes because. All right, C. Number 8, a 13-year-old girl is found floating face down in a swimming pool. Witnesses tell you that the girl had been practicing diving. After you and your partner safely enter the water, you should do what?
So we can continue. Well, we're not gonna enter bodies of water. So let's see.
So this is tough because you guys aren't really trained in this. Well, some of you. So D.
So wait, but wasn't D saying you just half of her body? Entire upper half of her body? Versus C is rotating her entire body. Well, the big thing there is supporting her head and neck.
Right. You can't unless you actually make a splint using her arms. There's two different methods, whether you're wearing a PFD or not, and how you're going to splint somebody using manual stabilization. So without a PFD on, you can hold like this. No, not this, right? Like this underneath, and you can go underneath the water. So you go underneath and corkscrew in. If you're doing it in shallow water or deep water with a PFD on, you would take the arms above their head like this here. You grab them like that, upside down, and you rotate in like this. That supports them. But you want to make sure you rotate their trunk because the body will turn with it. But you want to have forward motion as you rotate a patient in the water. Because if you don't, the trunk turns and the bottom half stays, and it kind of twists the spine. Versus a corkscrew, when you're going in moving water or movement of the water, with you moving in it, you go forward and you rotate like this, and their body will turn like that in the water. So that's the difference between them. All right. Number 9. Shortly after ascending rapidly to the surface of the water while holding his breath, a 29-year-old diver begins coughing up pink frothy sputum with a dyspnea and chest pain. You should suspect and treat this patient for. It is. And number 10, 3 ambulances respond to a golf course where a group of 6 golfers are struck by lightning. 2 of the golfers are conscious and alert with superficial skin burns. Group 1, the next 2 golfers have minor fractures and appear confused, which is group 2. And the last 2 golfers are in cardiac arrest, group 3. According to the reverse triage, which group of golfers should be treated first? And see, what was that? All right, that was awkward. All right, so that is all I have for online stuff here. I'm going to close out the program. Skyla, thank you for attending the recorded session.